Hello, everyone. I hope everyone can hear me. I'm Dr. Aaron Goodman. I'm one of the hematologists and bone marrow transplant in sunny University of California, San Diego, and I'm broadcasting live from my backyard. I apologize if a dog or a kid wanders in, but this is the most I can make it work on a Saturday. But I'm excited to have everyone here. I give quite a few talks, but the best talks that I participate in are always the ones to patients, family members. This is why we do what we do. As a clinician who takes care of many patients with a variety of blood cancers, I see it, my goal is to educate my patients. That's something that we take very seriously, because patients need to be empowered and understand their disease, understand their option, so they can truly make good informed consent, because the decisions that we make as physicians and that you make as patients are quite difficult for some of these diseases, and we recognize that. So it's a privilege to be part of this talk with Grace, which is a wonderful organization where we can help kind of bridge this gap of confusion. So the whole point of this is to not be confused. And at any time after these talks, when we're allowed to, please ask questions. You can ask. We got some world-class experts here. I'm pretty pumped about it. And so please take advantage of this. Ask us anything on earth you want to. We won't hold back. We'll tell you exactly. I'll at least tell you exactly what I think. And I know some of my colleagues won't hold back either. And that's the point of this. Okay. So, and I want to point out one other thing before we get going on the talks, because, you have all your own physicians that you're seeing, and they're the ones seeing you and taking care of you on a day-to-day basis. We're kind of on the outside here. Okay. And there's no one right way to do this, which is what makes our jobs hard. So if you hear something different than what you're doing, it doesn't mean what you're getting is wrong. And again, we're not the nitty gritty of the individual patient. That's where all the answers lie, that we're not privileged to see as consultants or second opinions. So please keep that in mind as we're talking. Okay, so the first doctor that I'm going to introduce is Dr. Rajiv, who's a fantastic physician from the world-renowned Memorial Sloan Kettering. She treats myeloma, does cellular therapy. She does everything, but her biggest interest is plasma cell dyscrasias. She's involved in a variety of clinical trials. She's interested in digital health technologies and delivery transformation, and she has quite a few grants. She's one of our Grace patient education ambassadors. So I'm very interested to hear Dr. Rajiv speak, and the floor is yours.
Thank you so much, Dr. Goodman. Let me proceed to share my screen. But as I'm attempting to share my screen, just wanted to reintroduce myself. My name is Dr. Rajiv. I treat multiple myeloma, and also I'm an expert in cell therapies and currently work at Memorial Sloan Kettering Cancer Center. Do you all see the right screen? I think you do. Yes, perfect. So yeah, it's always great coming back to Grace. I've been a part of Grace for the past 1 year as a patient ambassador, and I'm so happy to continue this work. And this is actually the second blood OncTalk that I'm a part of. So it gives me great pleasure to be here back again and talking to you all. So the last time we dealt with some basics of multiple myeloma and touch base a little bit about CAR T therapy. Today, I want to talk about a little bit about bispecific antibody therapies in multiple myeloma, specifically some updates we've had in 2023, because compared to, let's say, early 2022, when we had no FDA-approved options in the market, right now in September 2023, things are quite different, and we can go over them very quickly. So again, just to refresh everyone's memories, including patients and caregivers, now multiple myeloma is the second most common blood cancer. And what it actually is an abnormal number of plasma cells that multiply in the bone marrow and that interferes with normal functions. Plasma cells essentially are white blood cells that becomes very specialized to identify and fight infections and cancer by producing antibodies. Some of the symptoms of multiple myeloma, which people may be aware of, include having anemia, kidney injury. It lowers your immunity, have unexplained weight loss, and it directly affects the integrity of your bone, causing fractures. It can cause holes in the bones, and also when all the calcium from the bone kind of leaches out to the blood, it causes high calcium levels, which again can go back and damage the heart and the kidney. Multiple myeloma presently in 2023 is largely considered an incurable cancer. However, it's a very treatable cancer in 2023 with all the agents we have available. And therefore, because of its incurable nature, we need continuous therapy in almost many cases to keep the myeloma at bay. The way I sort of explain to my patients is that you have to have your one foot on the gas pedal at all times. When you take your foot off the gas pedal, there's a high possibility that the myeloma can grow back, which we don't want. So we kind of hit it with some kind of therapy all the time. Now, the landscape of immunotherapy in multiple myeloma has changed quite differently in the past 5 years. Now, when we were treating multiple myeloma 5 years ago, we relied very, very heavily on conventional chemotherapies and stem cell transplantation. Immunotherapy is a type of treatment that uses the patient's own immune system to kill cancer cells, and instead of directly killing cancer cells like the chemotherapy that we all know of. Just going into the broad categories of immunotherapy, and I'm only highlighting here the ones that are FDA approved. One include targeted antibodies, including monoclonal antibodies directed against anti-CD38 or anti-SLAMF7. These are some drugs you may have heard of called daratumumab, isatuximab, and elotuzumab. Bispecific antibodies, they're also antibodies, but unlike the monoclonal antibody, which only attaches to one particular protein, bispecific antibodies, by the name bi, meaning two, they go ahead and attach to two different antigens or proteins. And we'll talk about this more as we dive deeper, but this is just a quick overview. There are two main targets on the myeloma cell called BCMA, that's B cell maturation antigen, and GPRC5D, which now have products that are FDA approved and in the market ready to use anytime we feel that a patient is appropriate. The two anti-BCMA bispecific antibodies that have been approved are teclistamab or Tecvayli and elranatamab, which is Elrexfio. The anti-GPRC5D CD3 bispecific antibody is called talquetamab or Talvi. And lastly, there's the adoptive T-cell therapy or the CAR T-cell therapy, of which two BCMA-directed CAR Ts have been approved, which is ide-cel or idacaptogene viclocel, and cilta-cel, which is ciltacabtagene autoleucel. Again, the focus of today's talk is mostly going to be bispecific antibodies, but it would be quite remiss of me if I don't have this one slide overview of CAR T options in myeloma, which are so important to many patients also. Now, in general, when we talk about CAR Ts, we are vastly talking about autologous CAR Ts, meaning we take the patient's own cells, manufacture them in the lab using genetic engineering, make them express some antigens that are like giving them a sort of magnet or a sword to specifically attack myeloma cells, and then give it back to the same patient. That's called autologous or self. Now, in autologous, the two therapies approved include those directed to BCMA, which is idacaptogene, which was ide-cel, which was approved in 2021, and cilta-cel, which was approved in 2022, early 2022. There are some experimental targets that are very promising, including GPRC5D, SLAMF7, CD38, and FCRH5. And keeping all that aside, there's also researchers are now working to develop allogeneic CAR Ts for multiple myeloma. Allogeneic, as the name implies, would be a donor, T cells derived from a healthy donor that are manufactured in the lab and are ready to go when a patient needs them. Again, these are all in the experimental stages and we don't have them quite ready for prime time yet. These CAR Ts are approved for patients who have progressed beyond 4 different types of treatment. Now, coming to the main focus of the talk, which is bispecific antibodies in myeloma. These are antibodies or proteins that bind to 2 different antigens. Now, when I say antigen, I mean protein. So if I use the word antigen, I'm using it interchangeably with the meaning of protein. If you direct your attention to this Y-shaped thing on the screen, that is the general structure of an antibody. And you can see that the one arm of the bispecific antibody is attaching to the BCMA protein of the plasma cell. Again, the plasma cell is the cancer cell. And the other arm is kind of attaching to the CD3 receptor on the T cell. The T cell is your immune cell. So what this drug basically does is when it doesn't go ahead and kill the plasma cell by itself, in fact, it latches onto plasma cell using one arm, it latches onto the body's own immune cell with the other arm, brings them together, and that bringing them together activates the T cell in many, many different pathways, and then the T cell goes ahead and kills the plasma cells. So it's a really cool way of killing. You know, it's a kind of like, you know, not being directly involved in the killing, but yet facilitating killing sort of a way. The two FDA-approved targets are BCMA and GPRC5D, as we talked about, and which we will be talking about much more. And there are some experimental targets like FcRH5, CD28, and CD138 that are in the market. Now, the FDA-approved bispecific antibodies in myeloma will be of most interest to most patients because these are what are readily available to you because they're commercially available, they're approved, and your doctors don't have to depend on centers that have their clinical trials open because, you know, they can order themselves if their center is able to support that. Now, it's approved again for patients who progress beyond 4 different types of treatments. So it's approved on the 5th line, basically, for patients. The anti-BCMA and CD3-directed bispecific antibody teclistamab was the first kid on the block, which got its approval in October 2022. And this was closely followed on its heels by the anti-GPRC5D and CD3-directed bispecific called talquetamab earlier this year in 2023. Elranatamab is the latest BCMA-directed and CD3-directed bispecific antibody that just got approved last month. So we now have 3 FDA-approved bispecific antibodies in myeloma, which is great news compared to just 18 months ago. The other bispecific antibodies for which we have a lot of clinical trials open, so should there need to be any, let's say, you know, you have a trial open at your institution and your physician is asking you to consider this, these are excellent trials that are going on, and after a detailed discussion with your clinician, you can think about enrolling into these. And broadly, I just classified it into BCMA targeting and non-BCMA targeting. So the BCMA targeting includes the Amgen 701, CC 93269, TNB 383B, the PF 068 63135, and the Regeneron 5458. The non-BCMA targeting bispecific we often use and how patients enrolled on trial is called cevostamab. Now, very briefly on what are the types of bispecific antibodies, and this diagram shows all the different designs and shapes and sizes of bispecific antibodies which are being developed. And these are all developed with the idea to increase their strength of binding to each cell so that the T cells can come in much more closer proximity to the plasma cell and go ahead and kill them. Now, I'm not going to go into any details regarding any of the designs, but I just wanted you to know what specifically do we look in bispecific antibodies. First and foremost, we look at what is the strength of binding to their target antigens, because the strength of binding is directly proportional to how much the T cell gets activated. The more the T cell gets activated, the more it goes ahead and kills the cancer cells sequentially. And, you know, the more effective it is at killing the cancer. However, the one price we have to pay is that it has significantly more side effects. So we now are trying to have this delicate balance in designing bispecific antibodies in which we temper the strength of binding with the safety signals. The route, the duration, and the frequency of administration is also something we are very mindful when we design clinical trials for bispecific antibodies. Now, I promise I won't go too much into data, but these 3 graphs were just so impressive that I feel like it would be very good for patients to have a quick look into what exactly are we as clinicians so excited about. Now, teclistamab, talquetamab, and elranatamab are the 3 bispecifics that are now available commercially. And the 3 big clinical trials that looked into these 3 drugs also looked into how many patients are responding and how well are they responding. So what I want you to look is how many of these patients are having what we call stringent complete response, which is complete response with no evidence of even light chains, complete response, which is the middle section over here, partial response. So in myeloma, when we treat a patient who has significant disease in their blood or significant disease in the form of an extramedullary disease, what we're always looking for is shrinkage of their tumor if it's an extramedullary disease, or if they have measurable disease in the blood, we want to see what is called as at least something that's better than a partial response. So the good responses that we always look for are anything that's better than a partial response, and this is called a very good partial response, or VGPR, a complete response, or a stringent complete response. Now, these are terms I'm sure that as patients you may have heard from your physician. So we are really happy that when a patient's cancer is progressing, the drug we give is able to elicit a response anything better than a partial response. So these three drugs, teclistamab, talquetamab, and elranatamab, was really, really successful at inducing really deep responses in patients who were heavily pretreated, in patients who had seen many drugs before. So roughly speaking, all of them showed like an overall response rate of anywhere between 60 to 70%. And 60 to 70%, I like those odds because these odds are in patients who have seen at least, at minimum, 4 different lines of treatment. And at maximum, there were patients who were enrolled in these trials who saw up to 12 different lines of therapies. Now, again, flash back to 2021, when these options were not there, patients who were heavily pretreated, when we give them a next line of therapy, our best hope was somewhere around 25 to 30%. So in the exact same population, to get response rates of 60 to 70%, that's great. And that's why a lot of us are so excited about these drugs now becoming more available. Now, I promise this, I will simplify this chart. And this is, again, a quick table that is showing a lot of the pivotal bispecific antibody trials and some of the data surrounding them. I will just be mostly focusing on our FDA-approved products, which are elranatamab, teclistamab, that's elranatamab here, teclistamab here, and talquetamab. Again, when we look at clinical trials, there are 2 or 3 big things that we look for. 1, what patient population are we treating? 2, how well are the responses coming in? And we look at that with something called as overall response rate. And 3, and most importantly, how toxic is this therapy to patients? So what we found was that, across these trials, across all these trials, and mind you, we typically do not compare trials head to head like this, but this is just for a comparison's sake, for displaying all these bispecific antibodies which are given in the same space. So for all these trials, the vast majority of people who were enrolled were triple class refractory, meaning they had previously seen an anti-CD38 monoclonal antibody, a proteasome inhibitor, as well as an immunomodulatory drug. So again, these were people whose cancers had seen a lot of drugs before. So that's good because that's exactly the kind of patient population we would be treating anyway outside of a clinical trial. So that's great. Now, looking at the overall response rate, again, elranatamab was showing in the initial magnetism trial, an overall response rate of 64%. Teclistamab was showing in the Majestic trial 63%, and talquetamab was showing an overall response rate of 74%. And look at that. This elranatamab 64% was in a population that was 91% triple class refractory. Now, across these 3 bispecific antibodies, it was only in the elranatamab trial that they started allowing people who had prior BCMA-directed therapies like belantamab, mafodotin, or any CAR-T therapies. The duration of response, again, was excellent. A lot of patients had an excellent duration of response, more than 1 year to 1.5 years, and that's great. And the safety signals, a vast majority of patients had cytokine release syndrome, infections, neurotoxicity, and these were all in the 60 to 70%. So what exactly are the pros and cons of bispecific antibodies? Now, the pros include they're very efficacious therapies. They're off the shelf, or they're readily available to patients. They are inducing, as we are seeing, durable or long-lasting remissions. It can be given in the subcutaneous route, which is a short administration time. And we also can give to older, frail patients, unlike CAR-T patients. There are some cons though, like there are adverse effects, obviously, with these immunotherapies, including cytokine release syndrome, neurotoxicity, and skin changes. It needs to be a continuous therapy. Right now, the way we give bispecific antibodies is that we are giving it as a continuous therapy until disease progression. So we're still working on when we can potentially stop these, but we don't have that answer yet. And what do we do when patients fail, or the patient's cancer fails these therapies? What exactly are our options? Can you do bispecifics after CAR-T? Can you do CAR-Ts after bispecifics? Again, these are some fields in myeloma that we're actively investigating. Very quickly, just touching base on the adverse effects, they include cytokine release syndrome, neurotoxicity, hypogammaglobulinemia, which means there's low levels of immunoglobulin in the blood, low blood counts, and also a new unique side effect that we are seeing specifically with talquetamab, which are skin, nail, and taste changes. How do we manage these? For cytokine release syndrome, we diagnose it by the presence of fever, low oxygen saturation, low blood pressure. But mind you, for most of these bispecific antibodies, thankfully, the grade of cytokine release syndrome or the severity of cytokine release syndrome and neurotoxicity is actually much less than what we see in CAR-Ts. We treat with IV fluids, tocilizumab, steroids, anakinra. These are all drugs that we give to mitigate cytokine release syndrome. Neurotoxicity is something we actively watch out for in all patients receiving bispecific antibodies. The way we diagnose is the presence of confusion, memory loss, delirium, seizures, motor symptoms, and signs of raised pressure in the brain, like having blurry vision and headache, etc. Neurotoxicity is very rare and thankfully very mild compared to some of what we have seen in CAR-Ts. The treatment is again very similar to cytokine release syndrome. We are increasingly starting to see that low blood counts and low immunoglobulin levels that are lasting long-term are now a problem with bispecific antibodies. And the way we diagnose them both is by doing blood tests. There's low immunoglobulin levels in hypogammaglobulinemia and also low blood counts, which we look by CBC with low WBCs, hemoglobin, and platelet count. For hypogamma, especially with patients who are highly susceptible to infections or COVID or have had severe COVID in the past, we give monthly infusion of IVIG until recovery. And for those with low blood counts, we treat with supportive care with transfusions and growth factors like Neupogen, Neulasta, Retacrit, etc. Talquetamab deserves a special mention because we have seen some unique changes like onycholysis, meaning the nails kind of separating off from the nail bed. There are some nail changes that happen, and also skin peeling, which is called palmoplantar desquamation. We typically tend to treat them with topical steroids, vitamin E, and lac hydrin solutions on the body. Now, what can the patient or caregiver do when receiving bispecific therapies, right? Adherence is key. As much as possible, follow the treatment plans because these are designed in a specific way so that the drug is present in your body at most times and they attack the cancer. And these are all clinical trial data driven, the frequency. So we would like for the patients to be as adherent as possible. Infection prevention, this is really, really huge. So when patients have specifically low blood counts or low immunoglobulin levels, we ask them to avoid crowded places as much as possible. And if you are in a crowded place, to please wear a mask in heavily crowded areas, in airplanes or in mass transit like New York City subways, where I'm from. Hand and body hygiene and wound hygiene is extremely important because all of these can predispose to infections. Getting vaccinated after discussing with your oncologist, since there we typically don't advise getting any live vaccines for those who are post-transplant, post-CAR-T, and even those getting bispecifics. And at the earliest sign of an infection, get treated at the earliest. That's so important. Symptom identification by the patient or caregiver is also important, like any symptom, be it with infection, or if you feel like you've been on bispecific for a year and a half and you've been having excellent results, but all of a sudden you're having a new bone pain, new unexplained weight loss, a new anemia, let the provider know. And these are some signs and symptoms of disease progression. How can we as clinicians try to make bispecific antibodies better? We are now looking at clinical trials to move these bispecific antibodies which are now approved in the fifth line setting to earlier lines. Like, can we do them in early relapse, like second line, third line, fourth line, for a better action? Because the whole rationale is that we are trying to see if we can utilize the body's immune system when it's a little bit more stronger, rather than at the fifth line or later when the immune system is all tired out after getting all these chemotherapy and also after trying to take care of the cancer for so long. We are studying this in combination with other drugs. There is the Majestic 2 study, which is looking at teclistamab, daratumumab, and lenalidomide. The Majestic 3 study, which is the teclistamab and daratumumab versus standard of care like dara-PD or dara-Velcade-dex. And also we are trying to combine with another bispecific antibody. There's a redirect trial in which teclistamab and talquetamab were combined together. And in a very few number of patients, we saw excellent responses in patients who had extramedullary disease. So all these are ongoing trials that we hope will answer some of the unmet need in multiple myeloma. How does the future look with these therapies? Now, I think that the way the field may turn into the future is that there will be better designs for these bispecific antibodies, which will have a higher antigen or protein binding, however, without increased toxicities. They potentially, once these majestic 2-3 trials and all read out, they may be brought to earlier lines of therapies. They could be, instead of being given as a monotherapy, they could be combined with other therapies like lenalidomide, immunomodulatory drugs, cell mods, etc. It potentially may be used as maintenance therapy in lieu of autologous stem cell transplantation, which is right now the standard of care. It could be used as it could be utilized as consolidation for less than adequate response to induction chemotherapy. And potentially, we are also looking at time-limited therapies guided by minimal residual disease negativity, because right now bispecific antibodies are given indefinitely until disease progression. And finally, how to sequence bispecific antibodies with CAR-T and other T-cell engaging therapies based on T-cell health and other exhaustion markers. Now, in summary, bispecific antibodies in multiple myeloma represent a completely new era in immunotherapies, with response rates in heavily pretreated myeloma ranging between 65 to 75%. Currently, there are 3 FDA-approved bispecific antibodies, 2 targeting BCMA called teclistamab and elranatamab, and 1 targeting GPRC5D called talquetamab. The current indication is after 4 lines of therapy as the 5th line, and studies are being conducted to move to earlier lines and also in combination with other drugs. The initial step-up dosing is usually in the hospital, followed by an outpatient administration model. And some of the adverse effects include cytokine release syndrome, neurotoxicity, hematologic toxicity, which is low blood counts, and increased susceptibility to infections because of hypogammaglobulinemia. And unique to talquetamab, there are skin, nail, and taste changes that we always keep track of. Thank you so much for listening, and I'm happy to take any questions at our Q&A session.
That was awesome. I definitely have some questions, but we'll get to that at the question and answer session. Someone needs to go on mute. I can hear something. I'm going to introduce the next physician. Let me pull up my stuff here. Hold on. Sorry. We got Dr. Marco Ruz, who is a medical oncologist who treats a variety of hematologic cancers, including leukemia, lymphoma, MDS, myelofibrosis. He has an interest in patients living with HIV, and he also performs bone marrow transplantation. Okay. He performs a lot of research in perfecting cancer treatments and improving patient outcomes. He's written many peer-reviewed articles. So it's with my pleasure to introduce him, and I'm excited to hear his talk.
In the first probably 20 minutes or so, we're just going to be reviewing what is the current data in terms of bone marrow transplant outcomes in patients with myeloma and lymphoma. I have no disclosures at this particular point. So the outline of the presentation is we're trying to first define what is a bone marrow transplant, or what a bone marrow transplant entails. What is the definition of autologous bone marrow transplant? What are the most common indications for this subtype of transplant? And then finally, we're going to review the survival for both lymphoma and myeloma. I always like to start these conversations by looking into, of course, this is nothing that we have to remember at this particular point, but like to just kind of look into where we are. This is the hematopoietic system. I always try to, when we start a sort of an idea, give us an idea as to where exactly we target or where we are working in terms of multiple myeloma, also lymphoma. As you can see here, this is what we call the stem cell, or the multipotential or hematopoietic stem cell, and this is the sort of the different sort of the lymphoid and the myeloid sort of pathways. And here we have the, on this side of the slide, the B lymphocytes in which we're going to concentrate, and this is where the majority of lymphomas develop. And on this side also we have the myeloid cell, where we have, sort of the plasma cells. So one of the first concepts that perhaps we need to just kind of make sure that we understand is a bone marrow transplantation equals to a stem cell transplantation. Sometimes we have this kind of two definitions, and they're about the same for certain caveats as we're going to go along in the presentation. So the first topic that we're going to discuss is what is bone marrow cell transplant? Whenever we have a patient with either myeloma or lymphoma, first, of course, we need to treat these patients. And of course, once we achieve something that we call a complete response in the case of multiple myeloma, also complete remission in the case of lymphomas. So we consider the option, of course, of bone marrow transplant. And the definition of autologous bone marrow transplant basically is a transplant for using your own stem cells. Along these years, I noticed that, of course, the bone marrow transplant does not entail anything surgical. It's just the placement of a line. And basically, the Society of Bone Marrow Transplant has changed its name about a couple of years ago, and now is called Transplant and Cellular Therapy, because that's where it truly happens. What we usually do, excuse me, once we have a patient who is in complete remission, we collect the cells via a catheter. We place a big catheter, and then we collect some of these cells. And of course, we just kind of start processing these cells to obtain those kind of CD34 stem cells that we saw in the previous slide. And then we can either prepare it and put it in a special place in the lab and prepare the patient for something that we call a conditional regimen, meaning more chemotherapy, to make a space for these stem cells and then put these stem cells back to the patient. So this is basically the same patient donating himself, if you will, those bone stem cells. This is called an autologous bone marrow transplant. Of course, this is a very simplified version, but this is what usually entails. There are many different steps in between all the different parts of, as you see here, in the collection, processing, and the reinfusion. There are so many different sort of multi-processor, or I guess sub-processes are going on those different processes. This item of cryopreservation, this was used really because of the COVID-19 pandemic, and of course we use that as a sort of a make sure that our cells are viable. And this was used more in terms for patients who were or had donors in the second kind of transplant that we're going to review. So this is autologous stem cell transplant. Basically, you're donating your own cells, your own stem cells. And this is something that we do for patients with myeloma, lymphoma, and many other conditions. Still, we do it. With the advent of any other new therapies, things are changing, of course, as we're going to discuss very likely in the Q&A discussion. But this is what we have at this particular point. Continues to be the standard of care for many conditions, meaning that depending on the circumstances, if there's truly indicated for the autologous bone marrow transplant. So then we have a second sort of transplant that we're not going to talk much today, which is the allogeneic transplant, in which you get cells from a donor. This is more, perhaps a bit more complex sort of a process. As you can see, once again, we need to make sure that this patient is in complete remission. This is usually used for other entities, exceptionally for myeloma and lymphoma. Usually this is used for patients who have acute leukemia. And of course, whenever we have this, again, you see kind of a similar process, but the collection happens from a donor who is a match. And the process of obtaining a match, of course, is very complex. So there's a different steps, different process. You look into the registries and so forth. Of course, look for siblings first, followed by registries, followed by other different sort of perhaps family members. And then, as you can see, kind of similar process. We have a collection here, we have a processing. There is more, I guess, logistically challenging sort of processing process to deal with the stem cells from a donor. Then we, in some occasions, we cryopreserve it, meaning we're put in a special place just to, because of circumstances, sometimes we don't use it right away. But if we can use it right away, of course, we deliver the chemotherapy, which is induction therapy, and we infuse these cells to the patient. This is the allogeneic transplant process, which is a bit different compared to the autologous transplant process. But of course, to work in a bone marrow transplant setting, it's not really quite easy. You need intense logistics. Of course, you need expert staff members. You need laboratories. We need stem cell process and immunotherapy laboratories. We need to closely work with outpatient and inpatient facilities. We do have sort of a housing facilities, like in our case, we have our patients close in one of the Hilton hotels that we have at this point. And of course, we need to just kind of have close connections with the national and international donor registries, which can provide us with some of the donor cells when we need it. But now we're going to concentrate on the autologous transplant. We're going to review some of the statistics. The intent is not to look into very specific statistics, but we're just going to go do a quick review as to how the field of bone marrow transplant is being contributing to the fight against myeloma and lymphoma. It starts with the beginning. This is sort of a bit outdated sort of information that I'm going to present the most updated info later. The most common indications for autologous transplant are basically myeloma and lymphoma, the two entities that we're reviewing in this case. And as you can see here, the number of transplants have been on the rise over the last probably 20 or 30 years or so. And this is a more updated information looking into the number of transplants that we perform per year back in 21. This is the latest info that we have. And as you can see, myeloma here and PCD, which is basically plasma cell dyscrasias, which are kind of similar entities related to myeloma, goes with number one for autologous transplant in about probably 8,000 cases. Here is the two different subtypes of lymphoma. Here, the non-Hodgkin's lymphoma, that perhaps is not as much as we used in the past because of the advent of development of many new strategies. And of course, here we have Hodgkin's lymphoma. You're probably going to hear that autologous transplant is also used for non-malignant conditions. It's also used. This is not intent to discuss this today, but for other entities, non-malignant entities, also autologous transplant is used, and also has been used in the past, or about 20, 25 years ago. Autologous transplant were used for breast cancer and some of the solid malignancies, but unfortunately the results were not quite as the expected one. So that practice has been abandoned at this point. So again, just kind of the same graph in a different sort of format. As you can see here, we have the non-Hodgkin's lymphoma and Hodgkin's lymphoma, perhaps plateauing in terms since the year 2015, just kind of with less than perhaps about probably the same number of transplants. But here you see an increase in multiple myeloma. And we're going to briefly talk at the end as to why this is the situation currently. This is the non-Hodgkin lymphoma. I picked the most common one, which is diffuse large B-cell lymphoma, but of course, there are many others. And as you can see, the number of transplants that have been happening over the last few years, with some peaks around the year 2015, and then a bit of a drop, as I said, likely because of the new, I guess, technologies that we have at this point that are being reviewed today. It's very interesting to note that in terms of autologous transplant, as you can see here, this is basically stats for the same number of transplants that we saw, but tackled by or divided by ethnicity. And as you can see, there are some interesting differences between, of course, non-Hispanic whites, Hispanics, non-Hispanics, Blacks, Asian, and other ethnic minorities. This is something that has been discussed these days because of the fact that there are some differences in terms of outcomes among the different ethnic minorities compared to other races. And it's very interesting to know this. And of course, more to talk, more discussion. There are currently new papers looking into this kind of discrepancies and of course, different outcomes that are going to be carefully looked at. I'm presenting here, of course, the multiple myeloma, and again, the plasma cell dyscrasias. Here's Hodgkin lymphoma, not the non-Hodgkin lymphoma, and this is something called follicular lymphoma, which we don't do as many autologous transplants as we used to do, but of course, this is still some of the entities that in which we use autologous transplant. Again, the same numbers looking to divided by ethnic or ethnicity. And as you can see, sort of along the years, how things have changed. You could say that probably is about kind of very stable sort of in terms of the numbers for the last probably 12 to 15 years. So no major differences. Kind of any information regarding, for instance, the age as to for recipients of autologous transplants, in other words, the age of the patients. As you can see, there is a bit of an increase in terms of since the year 2015 in the number of patients over the age of 65, which is very unique with the new methodologies and the new techniques that we have in autologous transplant, better care, better supportive care, better antibiotics, and more prophylaxis, more aggressive prophylaxis, and the fact that we got more experience over the last probably 30 to 40 years with autologous transplant. That's where we're tending to more and more to have transplants on patients of the age of 65. Important to note also that with the help of some of the geriatrics scores, or we're just kind of transplanting more and more of these patients. But of course, the less than 18 is kind of very minimal, but usually the one in between is between the age of 40 to 64. And as you can see, there's an increase in numbers since the year, roughly since the year 2009. Something that we're looking to when we talk about transplants is basically comorbidity index, which is the amount of conditions or diseases that patients may have before transplant. And as you can see here, it's very interesting because this is basically divided into by ethnicity. And as you can see here, the majority of patients, of course, come with no comorbidities, I should say. Some of them comes with a few of the comorbidities, but less, of course, when we get or talk about a score of 3 or above, we're having some problems because there's more risk to having complications. Not necessarily related to transplant, but related to all those comorbidities. Comorbidities means, for instance, if you have some cardiovascular problems, lung problems, and other things that may cause trouble after the transplant. The same, again, as to how it's been divided by age. And as you can see, of course, less than 18, and in the younger population, they're not as much as with the senior population. But of course, there's still some issues in the young population, especially for patients who are sort of patients who have many of these complicated comorbidities just before the transplant. So to end the talk, we're going to talk about survival and basically how transplant has affected outcomes in patients with lymphoma and myeloma. And here we have the survival for patients with multiple myeloma, and this is kind of depicted from the years over the last probably 10 to 15 years. In patients with myeloma, it is very important that when we talk to patients, we talk to them about the fact that the transplant in multiple myeloma has changed something that we call progression-free survival, not necessarily overall survival. But it's important to talk to patients, especially depending on the risk stratification about transplant. So there is more still, there is a long way to go because as you can see here, when you look into the myeloma curves, basically it's something that is kind of plateauing, if you will, and it gives you the impression that it is decreasing, but that's not the case. Because of the fact that, as I said, with a transplant versus non-transplant, sometimes there's a discussion as to whether you can do the transplant early versus late. The recommendation is always to proceed with transplant. There are research certifications. Of course, there could be some caveats, but that is something that, of course, is up for discussion. With the other entities, as you can see, there's also some other significant benefits. In the case of Hodgkin lymphoma, also improved, so the progression-free survival. But again, with the new technologies that we have at this point is up for discussion as to what is going to be at the end, sort of the next strategy. And I think but this is a very exciting time because we have so many different technologies and options at this point that we didn't have perhaps 20 years ago. And this is something unique that is very important for us. So I guess in summary, just kind of to wrap it up, the presentation, autologous transplant still has a significant place in the care of patients with hematologic malignancies, as we review, especially with myeloma and lymphoma. Number two, there's nothing surgical about a bone marrow transplant. This is basically more cellular therapy. And that is why the organization, national organization, has changed its name from the American Society of Bone Marrow Transplant. Now is the American Society of Transplantation and Cellular Therapy, which is the right name to do. There's number three, there's always a, we'll try to obtain the best response, meaning the best, something we call complete response before we proceed with transplant. Sometimes it's not feasible, but it still will proceed. There is a significant increasing numbers of autologous transplants, especially for myeloma, some from lymphoma, because of the presence of new technologies and new treatment options at this point. Number four, still, autologous transplant represent a very viable option, and of course, still save the lives of our patients. And with that, I'm gonna finish. And thank you very much for your time.
Okay, we're gonna do some questions for our last two great talks. I'll start, but then I don't know if Maria's there. She can hand me any questions from patients. I want to get to those. Those are going to be a priority. But I'll ask the first question. Either of the last two speakers can answer this one first. So I'm a stem cell transplanter. My practice has changed a little bit over the last few years with stem cell transplant and myeloma, based off some of the recent data. So in young, healthy patients with standard risk disease, are you who have no contraindications to transplant, are you uniformly recommending autologous transplant to these patients?
Yeah, okay. I was thinking Dr. Ruiz would probably want to go first, but I'm happy to take the question as well. I think, you know, with the data we have, it's still, you know, transplant eligible, young, fit patients, and as you emphasized, Dr. Goodman, standard risk. I think most often my conversation with them is to consider stem cell transplant as a means of consolidation. Yeah. I mean, there's so much data we can go over, which, you know, can be for or against, but it hasn't changed my practice so much yet. But I think in the next few years, we will have some answers as to whether stem cell transplant continues to be the best sort of consolidation therapy versus should we consider CAR-Ts or other therapies as consolidation. But for the large part, my practice for standard risk patients has not changed yet.
And adding to that, of course, there are some changes in terms of the transplant practices over the last few years for myeloma, but it's still, as if you have a standard risk young patient, of course, transplant, early transplant as opposed to late transplant, you know, number one, much better. Number two, you know, some other, you know, we can discuss forever about, you know, the possibilities now with the development of CAR-Ts in myeloma. But it's still, you know, transplant has a significant role, significant place for, you know, for myeloma patients. And in this case, as you pointed out, Dr. Goodman, absolutely, you know, we'll go for transplant, early transplant is the way to go.
Yeah, just because I have just so I want, you know, patients to hear different opinions on this. So there's no right or wrong answer to this, at least in my opinion. And I will say most of the practice is to transplant up front, standard risk, those eligible. I disagree a little bit. I will say that with the most recent data, especially the determination study, and we won't go into the specifics. So transplantation, I want the patients to understand this. So transplantation, although in myeloma, we can get almost all patients through it safely, it still is a big deal. There is a decrease in quality of life, usually for 60 to 90 days around the transplant. You have to sometimes be admitted to the hospital or do it outpatient. And I think the most recent data suggests that we're not maybe potentially improving life and survival with an autologous transplant, meaning total years of life lived, whether you get the transplant or not, is the same, which I think is something we should be happy about. It means that our therapies for myeloma are getting really, really good. Now, that doesn't mean you shouldn't do transplant. Obviously, if you do a transplant in your first remission, your disease will stay away longer, right? I mean, you're giving more therapy. You're giving probably one of the most intensive therapies we can give. And but does that equate to patients feeling better and having a better quality of life? And that's where I sometimes struggle. I think in our brains, we think that if the cancer stays away longer, we will feel better longer. But it's not entirely clear from the data. That being said, I value a first remission like I think a lot of our patients do. Our first remission is typically the longest in myeloma. And once you relapse in myeloma, it's more therapy, which is not fun to do. So I think it does have a role. But where my practice has changed, and this I do feel strongly on, I used to recommend transplant for everyone. I would have a 73 or 4-year-old patient where I would transplant them. But I was a little bit borderline hesitant on it. I was like, is this the right thing to do? Now I do not. With our current therapies like daratumumab, Revlimid, dexamethasone up front, we can have very long first remissions without a transplant approach. And I might eat my words at this. Every decade or so in myeloma, we say transplant's going to go away with the new therapies, and it continues to have a role. I think this time we might get rid of it in the next decade with some of our bites and CAR T cells, but we have to wait for the data to show us that. So that's
I agree, Dr. Goodman.
Yeah.
I think the two categories which
Yeah.
I would first see transplant kind of going away is that, that borderline between transplant eligible and ineligible for whom we always consider, but those patients are whom we can kind of treat with the Maya trial data, which you just talked about, and also our high-risk patients. I really think for high-risk patients, the consolidation with other T-cell engaging therapies are going to come. So in that order, for like the borderline transplant eligible and high-risk patients, I think stem cell transplant may be first supplanted, followed by the standard risk fit patients. So yeah, I think it's going to hang around for some more time, but completely agree.
I think something that perhaps we need to just kind of take into account is I completely agree. The overall survival doesn't change, but something that perhaps I think we're, in my opinion, humble opinion, I don't think we're looking into the right indicators. Remember that transplant is a chronic illness. So as such, as you said, Dr. Woodman, patients are going to live just kind of long-term. And then there are some issues related to quality of life, of course, whenever you get a transplant and so forth. Something that perhaps we can just kind of work on, and perhaps not necessarily look into progression-free survival, overall survival, but other indicators that basically going to give us more ideas as to how patients feel and how patients do after certain things. Remember, bites, CARs also have some sort of significant issues. And for instance, we can argue with the CAR T-cell therapy, some of the patients, for instance, that were just kind of performing at my institution with lymphoma, believe me, it's not an easy ride. And then they get, and some of them, of course, a minority of them ended up in rehab. And then, of course, sometimes what happens with the development of CRS and ICANS, so that those kind of patients sort of course, have a very tough ride. So my point is perhaps we need to look into other indicators, not necessarily PFS or OS, to truly see what are the best therapy for patients. Of course, the more individualized approach as opposed just kind of to look into transplant CAR T bites versus something else.
Yeah, no, I agree completely. The best therapies for our patients make them live longer, feel better, hopefully both.
Right.
And I think with health-related quality of life, which I admit is something very hard to measure, what matters for our patients with myeloma, at least I think, not someone who's living with myeloma, is their health-related quality of life for their whole time with myeloma. Meaning, if the current therapy like transplant improves quality of life for the first few years because they're off therapy, does that offset, the decrease in quality of life if they'd gotten a salvage therapy sooner? So, and these are hard things to measure, but I plead and I hope with the community in myeloma that these are things that as our patients are living so much longer and our drugs are so much better, that the field start looking into these things, how to best sequence these therapies, how to de-escalate. And I know the field is getting there with some of the MRD adapted strategies, but we really need to look at how the patient feels for their whole time living with cancer, not just during the therapy they're getting that's being studied in the trial. I completely acknowledge it's very hard to measure that stuff. So my next question, this is another challenging one that I know is going to be patient dependent. And I think, but let's say we have a patient who is exhausted all standard therapies and they're referred to either of you two individuals. So when I say standard therapies for the patients, the IMiDs like lenalidomide, pomalidomide, they've had an autologous transplant, they've had Velcade, Kyprolis, they've had daratumumab, hopefully not selinexor, but they're getting there, and they are referred to you for consideration of CAR T versus bispecific. And now we have 3 bispecifics approved, and 2 CAR T cells approved. And let's say you're at a center that has access to all of them, and the patient wants to do what you think's best. And how do you have this conversation with patients, comparing the pros and cons of these 2 different therapies?
Yeah, absolutely. So again, Dr. Goodman, I think you threw us quite a bit of a big debate out here. You know, that's a big debate we have in all the conferences going through. But, you know, it's very rightly said, it's you know, now we have data from these 5 products that are available, either 2 CAR Ts and 3 bispecifics. So overall, you know, often if you look at a patient who is kind of has a good performance status, is of a younger and fitter age. So we are kind of selecting for younger, fitter patients, you know, consciously or unconsciously. And if they are pretty committed to coming to your center and getting therapy, and they would like to have, I mean, we have had some busy professionals who just want to get this one therapy and be done with it and get whatever period of remission that they get. I think they are excellent candidates for CAR T. You know, CAR T has excellent overall response rates, up to 80 to 90% in heavily pretreated populations, both ide-cel and cilta-cel. So for those patients, I would definitely consider CAR T therapy. Now, there are patients who are like, no, I read CAR Ts can be aggressive on the body. I heard it's similar to transplant. And if for patients who had a rough transplant course, who are not quite up to a performance status as robust as those I would take for CAR T, and, you know, for those who don't mind getting those bi-weekly or monthly injections of bispecifics, I think those are patients like a somewhat more older and more frail patients. We can consider bispecific antibodies as well. Again, the data is there, the data for efficacy is there, safety is there, but it's also patient considerations, like what they want to do. There are few patients who I thought were excellent candidates for CAR T, but they were like, no, I'm really scared that the cancer will come back. I would rather prefer something that goes on every month. So we have had it both ways, but patient selection is important. Dr. Ruiz?
Absolutely. And it's very difficult, to be honest with you, because we do have now an institution, we're very lucky, we have access to all of them. And we're developing our own experience. So we're seeing now more of the elderly population. Now we're seeing the viral activations from the bites that, of course, they're not really, you know, sort of very common, but now we're dealing with CMV and adenovirus, like we're going back to the allo setting at this point with these individuals, but that we don't know, number one, of course, how to manage these patients because there are no clear guidelines. And again, it's kind of difficult. I guess the criteria as to in regards to how to evaluate a patient. Of course, if you have a young fit patient, a CAR T cell therapy individual, you know, sort of course, proceed with CAR. But as Dr. Tanika said, the problem is that they want a pill, you know, want an injection, and they're going to be feel really happy. I don't want to go to the CAR T. That's basically they say, you know, when you just mentioned about CRS and ICANS, they go like, no, it's not going to be a no. I'm not going to do it. I don't want to be in the ICU. I don't want to have this kind of problem. So very difficult. And then now with the recent literature as to how to sequence now CAR Ts versus bites is even more of a headache, because despite the fact that we have 5 different approaches now, we need to be very careful in what we do. So I guess it's a $1 million question, Dr. Goodman. It's very difficult to assess. I guess it depends on the patient and depends on the experience of the center. For instance, now we're considering, are we going to do bites for geriatric patients? Because this is very unfortunate. We're tending to see now more complications. Frail patients develop, as I said, viral activation, C. diff infections, things that perhaps are not in the label of the products, but we are acquiring more experience. So we're talking to other centers as to how we can just kind of manage these complications.
Yeah, there's no right answer. And, you know, I think the big, for me, I mean, it's patient values. Like I know for myself, I would want to have a one and done type of treatment. Although I've definitely seen, you know, the CAR T's not, although fancy new, it's clearly not a benign intervention and can have some serious complications. We have a question from the audience that either of you just jump in and do it. I don't know if you're able to read it also, but I will read it. I am currently on Pomalyst 2 milligrams, daratumumab, and prednisone for 1 year and doing well. I also do alternative medicines, including taking cordyceps, which someone will have to tell me. I don't know what that is, but maybe one of my panelists does. The cordyceps makes me feel better, but I read that people with myelogenous cancers should not take it. Is multiple myeloma a myelogenous cancer?
Right. I think I just typed in the answer because I wasn't sure if we were getting to it. But just to make that clear, Dr. Ruiz in his beginning slide had shown this sort of chart that shows myelogenous originating cancer. I mean, the myeloid origin of white blood cells and lymphoid origin of white blood cells. So typically any cancer that comes from that myeloid portion they tend to be leukemias, myelodysplastic syndromes, MPNs or myeloproliferative neoplasms, etc. Myeloma and lymphoma tend to be lymphoid diseases, but I think that clarifying that science part aside, I think what all of us as physicians would advise you is that, any supplement you take would need to be vetted by your oncologist and also your oncology pharmacist, because they are far more familiar than all of us, I would want to say, with the exact kind of drug interactions that the particular supplement will have, and especially the dose you take and the frequency you take. I've had so far one patient who has had cordyceps, and cordyceps is like this fungal derived protein that people take, particularly for fatigue, is what my understanding is. But, I think when that patient came, what we did was, our pharmacist went through all the supplements they took, and then they kind of said, okay, this is the dose, that's okay. But anytime you take any drug, please disclose it to your oncologist. I can't emphasize more on that.
Correct. Those are lymphoma, myeloma report on the lymphoid part. That's the reason I just kind of wanted to show that sort of different algorithm, the stem cells, myeloid, and the lymphoid part. Yes, the cordyceps is basically more of a protein derivative, as Dr. Tanika said. Yes, indeed. I think we come across, of course, exceptionally, but some patients do it for protein supplementation, so extra, so trying to avoid complications associated with perhaps the conditioning, this, and so forth. Recommendation was always talk to your pharmacist, make sure your oncologist know about this to avoid some interactions that we don't want.
Okay, we're going to have to wrap it up, but I want to thank my two colleagues for wonderful talks and answering some of those difficult questions I asked. So, and I hope to see you guys in the future in person. So we're going to move on to the next set of talks, and we'll change gears a little bit. So I want to introduce my wonderful colleague, Dr. Tunisia, who's a senior fellow at Roswell. And who has much research experience in lymphoma and myeloma, working in a lab, also at the NIH. Her interests are hematologic malignancies, including lymphoma, myeloma. She's also interested in global and urban health equity, which she studied while she was in residency. So I'm going to let her talk. Ooh, it's a very controversial topic. I have lots of opinions on this, but I'm going to let her take the driver's seat first. So she's going to go over treatment options for smoldering multiple myeloma.
Thank you so much for that introduction, Dr. Goodman. It's such an honor to share the stage with you today. I'm unable to start my video. Okay. All right. So I'm going to be talking about this very controversial topic about treatment options for smoldering multiple myeloma. Let me start my presentation mode. All right. So I have a few objectives for my talk today. I'm going to begin with just talking about how we can define smoldering multiple myeloma and high-risk smoldering multiple myeloma. And I'm going to be talking about the treatment options for patients with smoldering multiple myeloma. And lastly, touch upon some lifestyle interventions for these patients as well. So, in terms of what smoldering multiple myeloma is, multiple myeloma or plasma cell disorders occur across a spectrum. So there's a B cell in the bone marrow, which is called the post-germinal center B cell, which acquires some mutations, gains some clonality and develops something called monoclonal gammopathy of undetermined significance, or MGUS. MGUS is, the first precursor state, and essentially this spectrum consists of increasing number of plasma cells and symptoms. So MGUS patients have the least number of plasma cells, actually by definition less than 10% in the bone marrow, and they have smaller M spikes, which is the monoclonal protein which we check in the peripheral blood, as well as less protein in the urines as well. And apart from that, MGUS and smoldering multiple myeloma patients do not have adequate number of plasma cells that is suffice to cause symptoms in our patients. An intermediate stage between MGUS and multiple myeloma is called smoldering multiple myeloma. These are patients that have a lot of plasma cells, but not enough yet to cause symptoms. Essentially, if you have 10 to 60% of plasma cells in your bone marrow, you do have smoldering multiple myeloma. At the same time, you have a higher M protein, a higher free light chain or a lower free light chain ratio, and more proteins in your urine. When you have multiple myeloma, you now have disease, you definitely need treatment. You do have symptoms now from this disease. So why I'm talking about smoldering multiple myeloma and why it is a controversial topic is because it is, at the end of the day, a heterogeneous disease. While we know that there is a progression from MGUS to smoldering to multiple myeloma, the genetic framework of these three disorders are oftentimes similar. But there are other factors, often called host factors, which could be responsible for the progression of the disease from MGUS to multiple myeloma. While at the smoldering stage, some of these cells might act like MGUS, and some of these cells might actually act aggressively like multiple myeloma. So while they might be meeting the diagnostic classification of smoldering myeloma, some of these might biologically act like MGUS cells, some of them biologically act like stable cells, and some of them biologically act like multiple myeloma cells. Based on how active these cells are, we could have different treatment options for these. For example, patients who act like MGUS could just be observed over time. Patients who have more stable disease could undergo some preventive treatments to prevent progression to multiple myeloma. And patients who are already biologically identical to multiple myeloma cells might benefit from early treatment. Sorry about that. So I'm going to be talking about how we can identify these smoldering multiple myeloma patients who are more multiple myeloma-like. Different studies and different trials have tried to find high-risk features in these patients in order to identify who would have the highest risk of progression. After looking at all different studies, there were some common factors that have been associated with patients having a 50% risk of progression at the 2-year mark. Some of these criteria are a monoclonal protein in the serum of more than 30 or 3, an IgA subtype of smoldering multiple myeloma, immunoparesis, which is described here as the reduction in your IgGs, IgMs, or IgAs, either of all of them. If you have a free light chain ratio involving the involved and uninvolved light chains of more than 8 or equal to 8, but less than 100, you're at a high risk as well. If you have a progressive increase in your M protein level, which is sometimes called evolving type of smoldering multiple myeloma, wherein your serum M protein is increasing by 25% on 2 successive staging workups performed within a 6-month period. If you get a bone marrow biopsy and you're found to have 50 to 60% plasma cells, if you have an abnormal bone marrow plasma cell immunophenotype and reduction of the uninvolved immunoglobulin isotypes, if you have some translocations such as 414, if you have deletion 17p or 1q gain on your FISH studies, if you have plasma cells which are circulating in your peripheral blood, if you have an MRI with diffuse abnormalities or 1 focal lesion, if you have a PET scan with increased uptake but no osteolytic lesion, which is the hole in bone appearance we call for myeloma patients. I'm going to be talking about this 2-20-20 model, which is widely used and recommended by IMWG for finding out who the high-risk smoldering myeloma patients is. While this model is not perfect, it is easy to calculate because it only requires 3 parameters, which are a serum M spike of more than 2, a free light chain ratio more than 20, and a plasma cell percentage in the bone marrow of 20% as well. As per a study done by Lakshman et al., which was published in Blood Cancer Journal in 2020, 3 cohorts of patients were found using these criteria. Low-risk patients who have 0 of these high-risk criteria, intermediate risk patients who have 1 of these criteria, and high-risk patients who have 2 or 3 of these criteria. Based on these groups, we found that high-risk patients had about a 46% progression at 2 years into multiple myeloma. So what is the approach to treatment of smoldering multiple myeloma? Essentially, there are 2 extreme ways of looking at this disorder. We could have more of an immunological or preventive approach to treatment, wherein we are not really targeting the malignant plasma cells, but we are targeting the immune environment in which the plasma cell is. The benefit of doing these therapies is that they are associated with fewer side effects. As we know, the chemotherapy or immunotherapy, CAR T cell therapy for multiple myeloma is associated with increased risk of side effects. But by following this approach, we can limit some of those side effects while still giving our patients some treatment. While these treatments might be slow to act, the results can often be long-term. However, in most studies, the response rates using these approaches could be lower than when we give a conventional chemotherapy or myeloma-like therapy for these patients. And the myeloma cells still persist because we are not really hoping to target them as much as we are trying to improve the immune environment. On the other end of the spectrum, we do have intensive chemotherapy, which has a curative intent. Now, definitely, we see a higher response rate with such treatments, but these results are short-term and are associated with sometimes even MRD negativity, which is also a deeper response. However, these patients will have increased side effects, and there is a hypothetical theory that by targeting the malignant plasma cells early on in this stage of disease might cause their resistance down the line. Or we could also be targeting in smoldering multiple myeloma the more populous normal plasma cells, which could actually cause an escape of the malignant plasma cells, causing an even quicker progression of disease later down the line. I'm going to be talking about some clinical trials that have found that treating patients with high risk or otherwise smoldering myeloma has shown benefit. So the first trial that was published in this space was in 2013 by Dr. Mateos, who's in Spain. And the trial was called Coredex trial, which looked at induction treatment with Revlimid, followed Revlimid and dexamethasone, followed by Revlimid maintenance for 2 years in high-risk smoldering myeloma patients. We did find in this study that the time to progression for patients who did receive Lendex was 9.5 years, as compared to just 2.1 years in patients who were randomized to just observation. Similarly, we also found that the overall survival at the time of this analysis was not reached for patients with Revlimid dexamethasone and was 8.5 years for patients who underwent observation. While these results are very promising, I'd like to bring out some critique that we have for this paper. Firstly, it was published in 2013, wherein some of the newer criteria for diagnosis of multiple myeloma did not exist. And we do think that some of these smoldering myeloma patients enrolled in the trial actually would be treated like multiple myeloma patients if they were to be treated right now. Otherwise, also, the study did include high-risk smoldering multiple myeloma patients, but the classification was very varied and did not, really include the 2020 criteria that we have at this time. Another trial published later in 2020 was the SCHEMA trial, which was done by Dr. Loniel from Emory. And he essentially studied whether patients with smoldering multiple myeloma across all risk groups should be given lenalidomide versus observation. So in this trial as well, he found that the hazard ratio for treatment with lenalidomide versus observation was 0.28. And in a subset analysis of patients across different risk criteria based on the 2-20-20 classification, the hazard ratio was 0.15 in high-risk patients and 0.5 in intermediate risk patients, again telling us that the major benefit of treating patients in smoldering myeloma has been seen in the high-risk population only. I'm also going to talk about some other early or phase 2 clinical trials, which involve patients for intermediate to high risk disease as well. And these somewhat come in the middle of the spectrum. They're not really preventative. They're not completely curative, or at least the intent is not, but we're trying to target something in the middle. So different studies have looked at different regimens in the phase 2 trials, including elotuzumab, Revlimid, dexamethasone, exidastimab, Revlimid, and dexamethasone, carfilzomib, Revlimid, dexamethasone for 8 cycles, followed by Revlimid maintenance, daratumumab monotherapy, different regimens in different arms of patients, and then isatuximab monotherapy as well. While these studies have smaller number of patients at this time, they have shown great overall responses in the range of 80s to 90s. And some of these patients also have MRD negativity, including sustained MRD negativity over 5 years in the trial, including KRD for 8 cycles, followed by maintenance. The efficacy of adding another agent to the backbone of Revlimid dexamethasone in smoldering multiple myeloma has actually shown in these trials to be better than when we do the same for myeloma patients. Ultimately, I'm going to be talking about some curative strategies for treating high-risk smoldering myeloma. And first, I'm going to be talking about the GEM-CAesar trial, which looked at 90 patients with high-risk smoldering myeloma. They received KRD for 6 cycles, followed by autologous stem cell transplant, followed by KRD consolidation for 2 more cycles, and then Revlimid dexamethasone maintenance for 2 years. We saw very high rates of MRD negativity in this trial, with up to 52% being MRD negative by the time of maintenance. At the 5-year mark, 94% of patients were still alive and progression-free. Recently discussed ASCENT trial from the Mayo Clinic also has a curative approach to treating high-risk smoldering multiple myeloma patients. Also consists of induction treatment, consolidation treatment, followed by maintenance. So the induction treatment included carfilzomib, lenalidomide, daratumumab, dexamethasone, followed by 4-week cycles, again for 6 cycles of consolidation, and then maintenance with daratumumab and Revlimid. It was well tolerated overall, with 43% of the patients, though, having more than grade 3 adverse events. Grade 3 adverse events are, intervention are adverse events that require intervention, with grade 4 requiring often hospitalization, and grade 5 actually implied death. So 43% of the patients did have those side effects as expected by following this curative approach. Some of the side effects were fatigue, diarrhea, constipation, cytopenias, insomnia, dyspnea, rashes, which are individually seen with these drugs, even in patients with multiple myeloma. Ultimately, I would like to talk about some other interventions that we can follow for patients with smoldering multiple myeloma, regardless of risk. And I'm going to be talking about some evidence for that. Dr. Urvi Shah from Memorial Sloan Kettering has studies called the Nutrivention studies, wherein she is looking at interventional nutritional approach towards patients with precursor states of plasma cell disorders such as MGUS and smoldering multiple myeloma. So the first study that she had was the Nutrivention study, wherein she provided patients with a whole food plant-based diet and nutrition counseling every 12 weeks. She monitored these patients and looked at various parameters, including their myeloma staging workup, looked at some of their lipid levels, hemoglobin A1C, insulin, inflammatory markers like ESR, CRP, IL-6 levels. And then she also studied their microbiome to see if, a plant-based diet was improving the microbiome to a state where the microbiome would be more likely to kill the cancer cells. She did include patients with a BMI over 25 for this study. So she had some very good results published in American Society of Hematology annual meeting in 2021, wherein she found that the BMI had reduced by 7% at 12 weeks for these patients. The A1C had improved by 10%. LDL cholesterol, insulin, IGF-1, adiponectin and leptin ratio had improved for patients over 12 weeks as well. In terms of the microbiome, she did find an abundance of stool butyrate producers as well as levels in these patients. And butyrate has been, something that inhibits one of the pathways called the NF-kappa beta pathway for patients, in the progression from their smoldering to multiple myeloma stage, and even MGUS to multiple myeloma. So this is a beneficial producer to have in the gut microbiome. She similarly found that inflammation had reduced over 12 weeks by following a whole food plant-based diet in these patients as well. She subsequently had two other trials called the Nutrivention 2 study, wherein she looked at not just whole food plant-based diets, but also supplements such as omega-3 probiotics and curcumin in patients with smoldering multiple myeloma. And ultimately, she had the Nutrivention 3 study, which was looking at placebo versus whole food plant-based diet and nutritional counseling in patients with MGUS and smoldering multiple myeloma as well. She does have some exciting results, which she'll be publishing in or presenting at the IMS meeting next week and subsequently in ASH later this year. So, we should all look out for how these dietary interventions are affecting outcomes and progression of patients with smoldering multiple myeloma to multiple myeloma. So in summary, smoldering multiple myeloma can be treated on a case-to-case basis, especially if it's associated with high-risk features. Ultimately, the ideal way to treat patients in this time and era is to enroll them in clinical trials, as there is a gray zone and a paucity of literature telling us exactly what we should be doing at this time. If you don't want to treat smoldering multiple myeloma, you should definitely look into lifestyle measures, which more and more people have been studying can affect outcomes, especially for patients with plasma cell disorders. Thank you. I'm happy to answer questions in the Q&A later.
Thank you. That was an awesome talk. It was great to listen to that. And I can't wait to talk about the plant-based diet and smoldering myeloma, but I'll hold my opinions to myself until we get to the question and answer session. So this leads me to our last talk, which is going to be by Dr. Phillips, who got his medical degree from Rush University and did further training in my hometown, Cook County in Chicago, where I actually grew up. He did his fellowship at the University Hospitals in Cleveland before joining a little bit north of us in San Diego at City of Hope, a great institution where he does research in blood cancers and bone marrow transplant. He leads numerous clinical trials with targeted therapies. He's published quite a bit. So I'm very eager to listen to this talk by Dr. Phillips.
All right, thank you. I didn't know we were from the same hometown, so we can commiserate later about the sports teams.
Yes, we can. It's been bad lately. Yeah.
So I just wanted to give a brief overview of a newly approved class of drugs in non-Hodgkin's lymphoma, the bispecific antibodies, and do my best to sort of attempt to sort of illustrate sort of the promise we think they would have for patients with malignant lymphoma and sort of things that patients who actually receive these treatments should expect as they receive the drugs that have FDA approval. So this is my mandatory disclosure slides. This is what we'll go over. And then I'll start it off with a very interesting cartoon that will help understand when we speak about bispecific antibodies. It really is involving the patient's immune system, as you see to the left with the cytotoxic T cell. And then when patients with lymphoma, again, the B cell should indicate the cancer cell in this situation. I'll bet, because of some of the non-specificity of the treatment, it will actually attack normal B cells as well. But as you see, the antibody itself in the middle, which binds the T cell and the B cell together, and then thereafter, the T cell releases cytotoxic granules and will cause the death of the malignant B cell in this situation to induce clinical activity. So I didn't think there was a better way to sort of illustrate when we talk about what bispecific antibodies do. This obviously, picture's worth 1,000 words. So this is exactly what we refer to when we give you this sort of treatment. So in the most part, there are 4 bispecific antibodies that probably are most advanced in clinical development, 3 of which have FDA approval. Mosunetuzumab is approved in patients with follicular lymphoma. Glofitamab and epcoritamab are both approved in patients with diffuse large B-cell lymphoma. And then odronextamab has data in both diseases, but does not yet have an FDA approval. So with epcoritamab, it was approved based on the EPCOR NHL-1 study. And this slide here is really just to illustrate when a patient gets this treatment, sort of what you would expect as far as the treatment. So all of these drugs are given in what we call step-up dosing initially, and that's to reduce the risk of side effects. So the 2 main side effects that we worry about are one called cytokine release syndrome, or CRS. The other is immune cell effective neurological syndrome, or what we call ICANS. There are other side effects that we see with these class of drugs, such as fever, infection, etc. But those 2 are the main ones that most people come to mind when they talk about this class of treatment. So epcoritamab, when its step-up dosing, is given weekly. So it starts off with a very tiny dose of 0.16 milligrams, then goes to 0.8 milligrams, and then thereafter to the full dose, which is 48 milligrams. Once you reach the 48 milligram dose, the treatment is still given weekly for the first 3 cycles. Then it's given every other week for cycles 4 through 9, and then it's given once a month, and it's a treatment to progression or unacceptable toxicity. So keep that in mind. Remember, treatment until progression or unacceptable toxicity for this one. And now I will summarize efficacy later, but again, for a patient, efficacy is important, but also you want to know about the side effects. So as I mentioned before, the major side effects are what we call CRS and ICANS. And so as you see, CRS is most likely to occur during the step-up dosing, but more specifically, you are most likely to see CRS during the first full dose, which is on cycle 1, day 15. So those first 2 doses with a very small dose of epcoritamab very rarely causes any adverse events. But when you get the first full dose, you will see the incidence of CRS increases. And that's generally when it's a recommendation, the patients are hospitalized for at least 24 hours for observation. Because epcoritamab is given in a subcutaneous dosing, so sort of if it's injection under the skin like insulin, and it's not given through an IV, it is a slower absorption, so the incidence of CRS can linger a bit longer, but the observation period is only for 24 hours. So you get the injection, and then you're admitted for 1 day to be observed, and then you're able to go home. Concurrently, during step-up dosing, so cycle 1, day 1, cycle 1, day 8, cycle 1, day 15, and cycle 1, day 22, patients are concurrently given 4 days of prednisone, which is a corticosteroid, usually at a dose of 100 milligrams, or you can get Decadron at 16 milligrams for the 4 days. That's also as a way of preventing CRS in this patient population. After cycle 1 day 15, no hospitalizations are required. And after cycle 1 day 22, you are not required to continue to give high-dose steroids in these patients unless you deem it necessary. So also to the left, you'll see the median onset of when CRS happens. This is more so information for the physician, as again, the patient in this situation will be admitted to the hospital and observed. But the more encouraging thing is after cycle 1 day 15, the incidence of CRS is much, much less. And ideally, patients should be able to tolerate these injections without any other significant concern for CRS or ICANS. And then we typically worry about other side effects that may happen, such as infection, etc. You're also given some antimicrobial prophylaxis. So patients are typically given acyclovir to prevent reactivation of shingles, and also given Bactrim for PCP/JP prophylaxis. Next, we'll talk about glofitamab. So glofitamab is given as an IV infusion. It is as well given up in step-up dosing. Difference here being glofitamab is given at a dose of 2.5 milligrams on cycle 1 day 8, 10 milligrams on cycle 1 day 15, and then 30 milligrams is a full dose. It is also given with a pre-treatment of an antibody obinutuzumab. So those of you who have lymphoma, you've probably previously been treated with a CD20 antibody called rituximab. Obinutuzumab is in a similar class as rituximab, just binds in a little bit different location, but it is given as a pre-treatment in this situation to hopefully prevent incidence and rates of CRS and ICANS in patients prior to glofitamab. As well as what we talked about with epcoritamab, patients also will get steroids on the day of the infusion of glofitamab. They will get Decadron, typically at 16 to 20 milligrams. So that is fairly equivalent to the 4 days of prednisone, because Decadron has a longer half-life, meaning it stays in your body longer than prednisone does. And so it will typically stay in your body for about 3 days. So giving you the equivalent of 16 to 20 milligrams of Decadron will stick around for about 3 days in the body. Again, if we look at CRS, we will see a different incidence of CRS. So unlike epcoritamab, which was on cycle 1 day 15, the highest incidence of CRS with glofitamab is with the first dose, the 2.5 milligram dose that comes on cycle 1 day 8. Thereafter, you see a step down in the incidence of CRS, specifically anything higher than grade 1, which is important because grade 1 CRS, which is typically just fever, can be managed as an outpatient. You don't need to be admitted to the hospital for grade 1. For grade 2 or above, you typically will have to be in a hospital and observed, and other medications may be given. So in this situation, the admission will happen on the first infusion of glofitamab, whereas with epcoritamab, it was on the last infusion where you get the full dose. This is with the first initial dose. So if you get treated with these medications, these are the differences that will need to be teased out when your physician treats you, and the days that you'll be admitted will be based on when the highest incidence of CRS can occur. Now, as I said before, I will discuss efficacy. As you can see from this efficacy table, the complete response rate between the two drugs are fairly similar. Overall response rate is not very important with diffuse large B-cell lymphoma because, again, this is this is an aggressive cancer. So if we aren't curing this cancer, we're not winning. So a complete response is really the only metric that really matters in diffuse large B-cell lymphoma. So the 39%, the 35%, and the 30.8% with odronextamab are the important numbers that we really should emphasize when we treat patients with this. So about 40% of the patients will get a complete response, which means that those patients have a chance of hopefully being cured from their cancer. I'll bet the follow-up is still very short with bispecific antibodies. And as of yet, we don't know that they're curative to date. The duration of response, or DOR, is 15.6 months for epcoritamab, 18.4 months for glofitamab. And again, both agents are approved. And because CAR-T plays such a big part in our treatment paradigm nowadays, you see epcoritamab and glofitamab both have some efficacy data in post-CAR-T patients, again, with a complete response rate around 34%, 35%. For those who are refractory to CAR-T, you see the complete response rate does go down to 28% with epcoritamab, and has not been reported yet with glofitamab. So I think as these agents are approved now, we will start to get more sort of real-life information about how effective they are in post-CAR-T patients. Because of the experience of academic centers with using CAR-T and the inexperience of community sites with using CAR-T, the uptake of bispecifics will most likely be mostly in academic sites as the community physicians get more comfortable dealing with CRS. ICANS, as I mentioned before, is another event, but I can comfortably say that the incidence of ICANS or the neurological toxicities with these treatments are very low and really should not be the major concern versus CRS. Hopefully, as community physicians get more and more comfortable with managing CRS, these drugs will be utilized much more and will give patients an opportunity, especially those who cannot get to a CAR T center or don't have the social support for a CAR T center, to get a treatment that functions very similar to CAR T and does appear to be effective thus far. So just to summarize this again, the two bispecific antibodies, much more similarities than differences. As I mentioned before, and I guess I didn't clarify, epcoritamab is an indefinite treatment where glofitamab is a finite treatment, meaning patients only get 12 cycles. So it's about 8.3 months of treatment, then that treatment stops. We don't know which one is best. Time will sort of tell us that answer that question for us. But that is really the only difference between the two drugs other than the date when CRS is most likely to occur. I expect the initial outcomes with these treatments to be worse, just because I think the patients who will get bispecific antibodies now are much worse in the sense of their cancers are probably much more progressive. They have much more comorbidities than the patients that we saw in the initial clinical trials, because clinical trial patients are really ideal patients because they have to meet preset specified parameters, which most patients do not. Again, so no washout, so patients will likely have a lot of complications from prior treatments, and most of the patients who will get bispecifics today will be post-CAR T patients. And I think with time and community usage, we'll get a better idea of how these drugs will truly function in our patients. So I was thinking in the next 1 to 2 years, we'll get a better sense of how effective bispecific antibodies are in patients with relapsed refractory large cell lymphoma. And then lastly, we'll just briefly go mosunetuzumab. So mosunetuzumab is the only drug approved for follicular lymphoma. This is a study that was presented by Dr. Buddy. Again, step-up dosing, 1 milligram on day 1, 2 milligrams on cycle 1, day 8, 60 milligrams on cycle 1, day 15. Again, 60 milligrams on cycle 2, day 1, and then thereafter, again, 30 milligrams. Mosunetuzumab and glofitamab are given every 3 weeks. I forgot to clarify that point. Again, as I mentioned, with glofitamab, mosunetuzumab is also fixed dosing. So 8 cycles only if you get a complete response. If you do not get a complete response, you can go up to 17 cycles. And unlike the other two drugs in large cell lymphoma, there is no requirement for hospitalization. At the bottom, I put that they are exploring sub-Q dosing with mosunetuzumab, and here's the dosing schedule: 5 milligrams, 45, 45, and then 45 until either cycle 8 or cycle 17. This one has an overall response rate in this patient population of 78%, which is an important one. Complete response rate 60%. Unlike diffuse large B-cell lymphoma, overall response rate is an important parameter in follicular lymphoma because, again, this is a more chronic lymphoma, so you can live with this cancer. So you don't necessarily have to get a complete remission to have a durable outcome. The curve to the right is really more academic information, not very important. Just lets you know that in certain mutations, the response rate wasn't very different. The durability of response thus far, the median duration of response, time that you're on treatment, has not been reached. But 24 months, 53% of patients are still responding. Those in a complete response, meaning no evidence of cancer, the duration of complete response is 63%. Progression-free survival, time before the cancer has relapsed, is about 24 months, with 48% of patients still being in PFS without having a relapse. And then time to next treatment is not reached, and overall survival is not reached. So also very impressive sort of data for this patient population that receives this bispecific antibody. Now, again, CRS is still the major issue, a little bit different from the two drugs in diffuse large B-cell lymphoma. There isn't necessarily a step up or a step down. You see there are 2 peaks, one peak on cycle 1, day 1, and then another peak on cycle 1, day 15. Thereafter, the incidence of CRS decreases considerably. Majority of the CRS events are grade 1 and grade 2. As I mentioned before, grade 1 is generally the easiest to manage. Grade 2 does still require some hospital evaluation because, again, you may need other supportive medicines we can't give as an outpatient. And this table just sort of summarizes with mosunetuzumab versus odronextamab, which probably will be the next drug to get an indication. As you can see, overall response rate about the same, complete response rate about the same. The PFS at 24 months, about the same. Asterisk by odronextamab because they only reported out 18 months. So again, overall, these numbers appear very similarly. The incidence and usage will come into the simple fact odronextamab is a much more complicated treatment step up than mosunetuzumab, and then we'll have to see how safety plays out. So just to summarize, follicular lymphoma, there's only one bispecific antibody, makes sort of choosing easier, but where it fits is a bit complicated. Because follicular lymphoma, you can have a lot more treatments and you can use other drugs repetitively. It's a very crowded space. And with CAR T and follicular lymphoma, it's sort of a competition. There isn't a survival advantage that we know about follicular lymphoma. And so whether you use CAR T or a bispecific will be up to you and your treating physician and sort of how sort of your life sort of fits. A one-time treatment versus a treatment you'll get every 3 weeks, but will eventually still stop. With the sort of incidence of CAR T, you have to be near a CAR T center. You'll have to have social support. The bispecifics, more treatments, but again, can be given in a community setting. So as we move forward, I think these bispecifics will make a big impact in patient outcomes with lymphoma. More than likely, most of these drugs will move up. Either they'll be used in frontline with combination with chemotherapy, or they'll be used in a second line in combination with some of the other targeted drugs like lenalidomide and follicular lymphoma, and potentially chemotherapy and diffuse large B-cell lymphoma. So with that, I will conclude and hopefully finish on time and for the question and answer.
Thanks, Dr. Phillips. That was great. I'll start with you. I have a question. Do you think, so to bring the audience up to speed, in relapse refractory DLBCL, large cell lymphoma, CAR T cells are curative in a percentage of those patients. Do we think, based off your interpretation of the data, are we curing patients with bispecific antibodies in DLBCL?
We hope, but we don't know. So we don't know. So I would wholeheartedly advocate CAR T should be first, especially in a primary refractory patients, and bispecific should be there for salvage.
Yeah, I agree. Yeah, I think reaching for CAR T first, at least in the current era, although perhaps more toxic, is the way to go. So let me, with smoldering myeloma, so smoldering myeloma is in my opinion, it's not a cancer, it's a pre-cancer. And when I explain it has the ability to develop into cancer at varying rates for different individuals, but in many patients, including my father, he's okay that I say this, it will not develop into cancer, or at least hopefully not for a long time. And, when I explain smoldering myeloma to my patients, I try to explain it like a colon polyp, right? We all know what colon polyps are. You get a colonoscopy and you can have a polyp, and those have the ability to develop into cancer, but not all of them will. The only difference is with a colon polyp, we can easily resect it and eliminate the ability for that specific polyp to become a cancer. With smoldering myeloma and other precursor states in blood cancers, it's more of a difficult challenge. So I will ask any of my panelists, in today's era, off of a clinical trial, if you have a patient with smoldering myeloma who is high risk based off whatever criteria you want to use, there's unfortunately many different criteria schemas that make it confusing for physicians. Are you recommending treatment? What are you doing with the patient in front of you? They say, I want to do whatever I can to feel better and live longer. That's what they're asking for. And are you recommending treatment?
I can actually talk about this a little bit. I think when I first started seeing patients as a first-year fellow, I read the trials and I was not very convinced. I was like, this is a polyp. It doesn't need to be treated. And we can just monitor these patients, 4 to 5 months and see how they're doing and how they're progressing. However, in the latter end of my first year of fellowship, I did have a patient with smoldering myeloma who did have a tiny lesion on their bone marrow MRI. And we did not treat him, but soon he developed a fracture. And we really regretted not treating him at that stage because it is a high-risk feature. And I think a lot of what we do is related to our practice and what we we learn as we go. And I just thought that, since there is a 50% risk of progression at 2 years, it doesn't hurt to give somebody Revlimid for 2 years, at least if they have smoldering multiple myeloma. And, that's what we've been mainly doing in clinic. We do use the 2-20-20, but I think, any of the high-risk features should at least, alarm us a little bit, and we should take it as a case-to-case basis, like I said. However, interestingly, more and more we've seen diet and exercise, improving the T cell function and improving the microbiome, inflammation in patients, and they've been studied in patients with plasma cell disorders. So I think that is something we should definitely recommend to our patients. I know that is something we recommend to everyone, in general, but I think especially to our smoldering multiple myeloma patients, it might be more important if there are some interventional exercise or dietary studies, they should also enroll in those so that we can learn more and see if, this lifestyle change could, slower their progression.
Yeah. This is where you'll see disagreement amongst physicians, and for the patients, there is no right or wrong way to do this. It's clearly a long discussion on the individual level, but I will say my 2 cents. As far as diet and what I tell my patients, in every randomized study that they've done, meaning where they take patients with whatever entity, with what they're looking for, development of cancer or progression of cancer and they randomize to a dietary intervention versus just doing what they would normally do, there has never, ever been shown that any dietary intervention at that level targets a specific cancer, okay? And, all the data we have right now for dietary interventions in smoldering myeloma to prevent progression is looking at what we call surrogate endpoints, which looks at changes in microbiomes or levels of proteins, but not, those are surrogates for what matters to use the patients, is like developing progressive myeloma and experiencing morbidity from that. I actually strongly discourage, we should all eat a healthy diet. Do eat well, eat vegetables, exercise, but I do not want my patients to think with the current data that by doing that, they will decrease their risk of progressing to myeloma. And quality of life matters. If my patient has smoldering myeloma or MGUS and they like eating steak because that improves their quality of life, please do so. Okay. Please do so. You should eat healthy to prevent all these bad things from happening, but I don't want you fixating that you can control this or the progression of myeloma. The current data does not suggest that, in my opinion, and I would strongly discourage that. Now, as far as myeloma, many patients with smoldering myeloma will never progress. Actually, the majority, even in the new high-risk criteria, if you look at the varying data sets, and there will be prospective stuff published soon, many patients will not progress. And Revlimid is not benign. It's chemotherapy, and it's expensive, and it has side effects. Patients don't feel great on it. And I think it's just a risk-benefit talk with the patients as far as treatment. And the way I look at it is, we're getting there in smoldering myeloma. There are people or patients destined to progress, okay? And there are patients that are destined never to progress. And it's going to be based off genomic features that we're working desperately hard to figure out. So if you're one of those patients that is destined to progress to active myeloma, and you're getting treated with single agent Revlimid, we are under treating you, okay? You are getting inappropriate treatment because we treat myeloma with more than single agent Revlimid based off wonderful randomized data. If you are a patient who is not destined to progress to myeloma, you are getting overtreated, okay? So with the current data, I'm either undertreating or overtreating patients. And I just think we have to wait. I think we need to figure this out a little bit better before we jump into our treatments. Those are my 2 cents. I don't know if Dr. Phillips or anyone else has comments on that. And I want any questions from the audience.
Yeah, I don't treat myeloma, so I would be very ignorant to put a comment, but I do agree with you in the simple fact none of our studies have really shown diet makes a difference in outcomes for our patients, even in the lymphoma space. But I don't know the myeloma literature.
And I will say, in the lymphoma space, there are other indolent cancers that we treat, and they've done wonderful studies in CLL and other indolent lymphomas. The early treatment might make a scan look prettier, but it's not making patients feel better or live longer, and it's exposing them to therapies. And what I always tell my patients, it's very hard to make patients who feel good better, okay?
Very easy to make them feel worse, though.
Yes, yeah, we're very good in medicine, but a lot of we oversell. I'm not taking away anything that we do. We do miracles in oncology, but our interventions, we're in a modest gains business here. Most of our interventions are modest. And in patients with active cancer that are suffering from their cancer, those are huge benefits, sometimes those modest gains. But in healthy individuals, it is incredibly difficult to make them live longer and make better, especially in a safe fashion. So we need to be, and as a physician, if I have a patient in front of me who has metastatic pancreas cancer or acute myeloid leukemia with limited treatment options, I'm way more willing to think outside the box because the risk benefit there changes quite dramatically. But if I have a healthy patient who's feeling great, I need very strong data to recommend an intervention. Now, and this is where you'll see disagreements, but I do think the field of myeloma is getting there. They are doing wonderful studies to figure this out. I just think we have to wait a little bit longer. Oh, I just went on a rant. I apologize. So let's get some questions from the audience if there is any.
I see there's a question about the correlation between elevated von Willebrand factor and smoldering multiple myeloma. Well, actually, there can be von Willebrand disease, so there can be deficiency of von Willebrand factor that occurs secondary to MGUS and smoldering, perhaps. But if it's elevated, there's probably no correlation. But I'll, also ask Dr. Goodman and Dr. Phillips what they think.
Yeah, I'm unaware of the correlation. There are many things that can cause elevations in the von Willebrand factor, anywhere from sometimes even inflammation. So to my knowledge, there's no credible data on the level of von Willebrand factor. As she said, there is rarely cases where you can have a bleeding problem from myeloma related to deficiency of von Willebrand factor.
No, I would agree.
All right, so we have a question. That's a lymphoma question. A splenic marginal zone lymphoma patient in a 2-year clinical trial. I'm more worried about getting killed by C19, so COVID-19. I've had every shot and booster with very little uptake than I am about my lymphoma. Is there any hope on the 6-month horizon for better prevention and treatment therapeutics for the immune suppressed? We'll let Dr. Phillips take this one.
Yeah, I mean, the problem probably comes from if the trial includes rituximab, that is probably the reason why you're not responding to the booster. It is very good at preventing B cells from responding to any vaccination. So unfortunately, there's really no way around that. You can supplement things with IVIG, but really the thing is with these shots, the hope is that you'll get some sort of T cell response from the vaccine, so that will hopefully supplement some of your deficiency in B cell response from the vaccinations. But depending on what drugs you're receiving, ideally you would hope that once your treatment is over, that you should respond to vaccinations. We do have data that after a period of time, especially from you space out the time from a vaccination from a CD20 antibody, that you will respond as anybody else. It's really just getting some space away from your treatment into your cancer. Since your cancer isn't curable, if you are that concerned, then maybe you just stop the treatment and go ahead and give your body a chance to recover, then go ahead and get vaccinated. A lot of the stuff that are in these trials are probably drugs that you can get off of the trial. If there's something that you're concerned that you cannot get off of the clinical trial, then at that point, then you probably just want to finish out your treatment course and then continue, like I said, just to get vaccinated and, mask up and reduce your exposure to others in the community, especially while we having peaks. But that's really the only thing we can do, unfortunately, because again, with all the mutations, a lot of the things we used before probably aren't working, other than maybe remdesivir and things like that if you do catch COVID-19.
Yeah, I agree. With time is the thing, and that's why with splenic marginal zone lymphoma and other indolent lymphomas, we used to, at least I personally in my practice, I used to give rituximab maintenance to most of my patients based off it prolongs the remission. But in the COVID era, I've largely changed that practice to give my patients breaks off rituximab because risk benefits have changed in our current era. And I will say, fortunately, as this current point, I can just speak on our hospital, and I take care of a lot of immunosuppressed patients, transplant patients. We are seeing less severe COVID than we were a few years ago based off infections and good vaccination, but it still is a concern. So I would say if you're doing well, minimize treatment if you can. And I don't know the specifics of the clinical trial. Okay, so do we have any other questions here? can someone, there's a question. Okay, so what would be the next, so this is for our myeloma gurus. So what would be the next treatment option for someone on their first relapsed after a stem cell transplant for IgG kappa myeloma in January 2016? My first line of treatment was Velcade, Cytoxan, dexamethasone, so Cybor-D, and now taking 4 milligrams of Ninlaro for maintenance.
Oh, okay, great. So first of all, I'm really glad that you had, your first relapse probably what, 6-7 years after initial diagnosis. That's usually a good indicator of the kinetics of the disease. Your disease is not a fast growing disease, which is a good sign. Now, we often decide the next cocktail of treatment based on whatever drug you've been exposed to in before. So if you've seen Velcade, dexamethasone, Cytoxan as your first line treatment, and you've had stem cell transplant and Ninlaro for maintenance, it doesn't seem to me like daratumumab is something that your disease has been exposed to. So we have excellent data with all the daratumumab trials in first relapse, second relapse, etc. So that would be a very efficacious drug that I would first introduce in the first relapse setting. In terms of the daratumumab can be combined with an immunomodulatory agent or PI. Now you've seen Ninlaro as well as Velcade. So again, I think a daratumumab-based combination is what I would go for, either paired with lenalidomide, or if we can re-challenge you with Velcade if you don't have any peripheral neuropathy, or we can also consider carfilzomib as well as a pairing for with daratumumab. And the third drug would, of course, be a steroid backbone with dexamethasone based on how much you can tolerate it, 40 versus 20, based on your previous tolerance to dexamethasone.
Thank you. Are there any other questions, Maria? Question from the audience. Another myeloma one. I was diagnosed with multiple myeloma in 2021. I'm age 66. I have never gone into remission. However, I feel good, my blood work is good, and I have a pretty good quality of life. I'm fearful that I cannot survive a stem cell transplant, so I've decided not to undergo a stem cell transplant for now. I'm currently on treatment plan with daratumumab shots once a month and oral Pomalyst. Is there something better? How safe is CAR T option? What are the downsides of CAR T cell treatment? A lot of good questions in there from one of our myeloma physicians, if they would like to answer.
Sure. Dr. Goodman, do you want to tag team this question, because there are multiple components to it?
Yeah, I can do. So I can do the first one. I'm fearful that I cannot. So as a physician, I completely take into account your fears regarding transplant, and those are very reasonable fears. And as I spoke about earlier, unlike before, where we had 10, 15 years ago, we didn't have all these great therapies for myeloma. I really tried to push my patients towards transplant. But in the current era, especially in a 66-year-old, I don't think transplant, I don't tell my patients, don't feel bad that like you're wasting a great therapy. There are many successful ways that your disease can still be treated without a transplant. It is by no means an absolute in today's era. And I know remission status in myeloma is a little confusing. In many patients, if you, as she was explaining earlier, there's partial response, very good partial response, and there's all these crazy response criteria. But don't get hung up, in general, less cancer is better. But there definitely are patients that can have partial remissions, very good partial remissions, where their M protein's hanging around, and they can have years and years of remission. As a physician taking care of someone with myeloma, what I'm looking for and concerned about is not the absolute level of the protein in your blood, okay? I'm looking for it going up, and more importantly, are you experiencing sequelae or problems related from your myeloma? Are you becoming anemic? Are you getting new bone lesions? Those are things that I follow. So if your M protein stays elevated but doesn't move and you feel great, that's a win. Keep doing what you're doing. There's no need to change. There's no need to become more aggressive. There's no data that would suggest increasing your therapy will make you better. It might lower your protein more. So that answers the first questions. How about you answer the second set of questions? And feel free to
Absolutely.
chime in if you disagree.
No, I don't. I actually do agree. And I'm pretty sure in our patient panel, there are very few patients for whom we have that beautiful M spike of 0. I want patients to know that, for most of our patients, when they come in with an M spike of, let's say, 3 or 4 or whatever number, what we are looking for is a reduction and the percentage of reduction from that initial number. So as long as it's going down, it's in the right direction and staying there with your current daratumumab Pomalyst regimen, which, by the way, is actually a really good regimen. If you're able to tolerate it. Pomalyst is a very good immunomodulatory drug, which is very good at keeping myeloma away for a long time. I think that is good. What we look for is often being in that plateau stage with the M spike or the amount of cancer in your body. And we all very often look for any change or increase in those M spike numbers. So completely agree on that. Now, I think you were asking about CAR T as an option. Again, CAR T as an option will be open to you once you have, and hopefully not anytime in the near future, progressed beyond your second line and third line and fourth line of therapy. And then CAR T becomes an option based on the current FDA label. Now, CAR T is something that we do consider in patients who are somewhat having a good performance status, meaning, there are patients who are transplant eligible or people who we typically consider transplant ineligible for some reason, but we can have some other criteria for CAR T. Essentially, we look at if you're able to, do a lot of the home chores of your own. Take a shower, dress yourself, do a lot of your groceries and other stuff on your own. And you're essentially able to take care of yourself, and you have an exercise tolerance of being able to walk 5 blocks, 10 blocks, etc. That would make us consider that you could be a good candidate for CAR T. We do have to give some chemo to condition your body before we give CAR T cells to you. That's not usually considered like high dose chemotherapy, typically the way we think of stem cell transplants. So yes, you will be getting a dose of chemo, and that is going to be intensive. But then, after your CAR T infusion, I think between Dr. Phillips and me and Dr. Ruiz, we all talked about all the side effects that you can have following CAR T. Mainly, we watch you in the hospital for 14 days very closely for cytokine release syndrome, which is this massive inflammatory reaction when the CAR T cells expand in your body and attack your cancer. We also closely watch for neurotoxicity. And at the end of 14 days, you go home and then we continue monitoring. For downsides of CAR T, I can't really think of any. It's proven itself to be having a very good efficacy in very heavily pretreated patients. And yes, you do have to have somewhat of that robustness in performance status to be eligible. For alternatives, apart from CAR T, for patients who are not quite there with their performance status, that's when bispecifics come into the picture, right? Again, you needed to have progress beyond a few lines of treatments, but bispecifics have really opened the door for more options for you. And I think bispecifics would be a consideration for the next line of treatment should you get there.
Great. So this next one, we'll go to Dr. Taneja. Can you explain what a biochemical relapse is versus a clinical relapse in multiple myeloma?
Yeah, sure. So, biochemical relapse is based on, if I could just tell you in very layman terms, I would say that it's based on what's going on in your blood and your urine in terms of your myeloma tests, like your the protein electrophoresis we get, the free light chains that we check as well. And clinical relapse is, we call a relapse clinical when you have some symptoms that are clinically manifesting, when you have a relapse. So somebody might have a, new bone pain, a new fracture, in which case we would call that relapse a chemical relapse. We do have the International Myeloma Working Group criteria that can give us the best guidance in terms of assessments for progressive disease. And, we have to measure how much there has been an increase in the M spike and the free light chains in the blood, and the urine to, exactly define over 2 different time points progressive disease. Yeah, that's my take on that question.
Yeah, I mean, really, clinical relapse is what we're trying to prevent or at least delay in multiple myeloma. I mean, you're feeling bad related to your cancer. While biochemical is just a lab test that comes back, and you're feeling fine. Typically, though, biochemical relapse is going to happen before the clinical relapse, usually, or almost always. So I can only speak how I do it in my clinic. When patients are in a good remission, whether they're on or off maintenance, I will follow that protein in the blood on a regular basis. And if it starts going up, if it just goes up a little bit, and the patient feels fine, I watch it. And I've definitely had patients where that's what makes myeloma a hard disease to treat. I've had patients to get a transplant and like 6 months later, their M spike recurs and we're all freaked out. And then we watch it. And then like years later, it's just kind of staying there and nothing's happened. And I could have started treatment 3 years earlier, which would have been not necessary. And that's where the art comes in. So if I see a biochemical relapse, I will follow it closely. Now, if it goes from 0.5 to 1 to 1.5, we're in trouble. Okay. But if it just hovers around, I typically don't do anything or change my treatment plan. And this is just where a judgment call has to happen in a discussion with the patient physician. Okay, so we have we got a question for Dr. Phillips. It's kind of a tough one, but how successful are bone marrow transplants for lymphoma, and how can I increase my chances of success?
So most of the time we do transplants as in large cell lymphoma, and a lot of that has really nothing, unfortunately, to do with the patient, but more so the disease biology. Auto transplants, historically, we've used for relapsed refractory disease. Unfortunately, for patients with primary refractory disease, auto transplants aren't very effective. I think we have several studies that looked at outcomes, Scholar One, and more recently, the CAR T versus auto transplants indicated that axi-cell and lyso-cell are better treatments. These CAR T treatments are better than auto transplant in this patient population. So auto transplants seem to now be best reserved for patients who we consider to have relapse disease, meaning you get initial treatment. Generally with R-CHOP, your cancer stays in remission for at least a year, and then we salvage you for another form of chemotherapy, and then you will get an auto transplant. The auto transplant, obviously, really just being high-dose chemotherapy with stem cell rescue. So basically, they use your own blood cells to rescue your body from chemotherapy. So inherently, your cancer still needs to be sensitive to chemo to be effective. Follicular lymphoma, we have used auto transplant very rarely. Ideally, in the quote-unquote POT24 patient population, it increased sort of the highlight of the benefits of an auto transplant. But I think we're finding that POT24 is probably a misnomer, as the majority of these patients have transformed diffuse large B-cell lymphoma. And so I don't think any of us really know what a POT24 follicular lymphoma patient really looks like and whether an auto transplant is really beneficial in that patient population. Mantle cell lymphoma auto transplants are probably on the chopping block. We probably will stop doing less and less of that because of more and more clinical data. There are some trials that are still ongoing that are looking at the benefit of auto transplant, especially in the context of minimal residual disease. We'll see how that reads out. And the other ones, we really don't do auto transplants at all. Allo transplants in lymphoma are a bit more difficult. They are probably only curative intent in several of the indolent lymphomas, so follicular, CLL, MCL, Waldenstrom's, marginal zone. Allo transplant are probably the only curative intent for most of the patients, but they do come with complications, and our patients typically either don't have sibling matches or are not young enough for an allo transplant, so they are seldomly used. Also, your cancer probably needs to be in a complete remission or very, very good partial remission, still in from myeloma, to actually go to an allo transplant, which, is not always the case that happens. So for the most part, if you want to do things to improve your outcomes to transplant, if your disease is amendable, really just your fitness level is important, because there are a lot of things that will exclude you from being a transplant patient, whether it be age, lung function, cardiac function, et cetera. Those are the sort of controllable things that you have, is just to make sure that, A, you don't smoke, you try to stay healthy and active, and you eat a well-balanced diet. And other than that, a lot of the other concepts are really out of your control, unfortunately.
Yeah, again, it's really, unfortunately, it's your disease that was not your fault and nothing you can do. And in transplant, in aggressive like DLBCL, diffuse large B-cell lymphoma, in those late relapses, so meaning they get their chemo up front and the cancer stays away for a few years, let's say, and then comes back, auto transplant can still be quite a useful treatment modality that can result in cure. But for those early, or the lymphomas that never really go into remission after frontline therapy, the field's moving more towards cellular therapies, CAR T cells, due to the limited activity of auto in that space. So another question here, does bispecific treatment for lymphoma affect fertility? I can answer that. I don't think so. I don't know if Dr. Phillips has, there's no at least biological reason why I can imagine why it would. But I don't know if anyone knows some data about bispecifics and fertility in any of the diseases we treat.
No, I would think it wouldn't. I mean, it's just an antibody in this situation. So
yeah,
no more so than rituximab would affect fertility.
Yeah, so I wouldn't let that be a worry if that is something that you're in need of. Question from the audience: how much does treatment with bispecific antibodies cost? Is treatment available everywhere, or will I have to travel? And this is a great question. So the price is going to depend on a lot of things, but they're expensive. Okay. But insurances, at least in my practice, have been paying for it if it's approved and indicated. So if we're using it on label, most insurance companies will approve it. And I haven't had any of my personal patients had to have a huge out-of-pocket cost. I don't know if anyone of my colleagues has had that scenario. So yeah, everyone's shaking their head no. So I wouldn't worry about that. Okay. Your insurance has to worry about it, but you got insurance hopefully, and they're taking care of it. So is treatment available everywhere, or will I have to travel? So these right now, and please correct me if I'm wrong, most of these therapies are given at larger academic centers. I know at least in San Diego, our community practices are just starting or haven't yet. They're trying to get them going, but there is some infrastructure that needs to be in place for these therapies due to the side effects that are the cytokine release and the neurologic toxicity, although much more unusual with these than with CAR Ts. But there is a big infrastructure that needs to be in place. And we're spoiled at academic centers. We usually have transplant programs and nurse coordinators that can already absorb this infrastructure. So your local community practice probably does not, and you would then have to travel. And these drugs are given, depending on the indication, every week to 2 weeks to 3 weeks for quite some time. And that would be a travel. Do you guys have any experience where you guys practice with community giving these drugs yet, or no?
So I would say the one caveat is the travel period would probably only really be in the incidence where CRS is a concern. So it's generally the first month. So thereafter, I would say that these can be given in community settings after we go through the window of monitoring for CRS. So I think at least in the lymphoma world, the community sites can probably give the first couple of doses of epcoritamab and refer for the cycle 1 day 15 dose, or vice versa, have our stock glofitamab, and then the patient go back to the community as long as they have the drug on their formulary. That doesn't require the infrastructure, because that, in a sense, once that's taken care of, it's just like any other monoclonal antibody.
Yeah, I think it's the same for myeloma as well. And especially there have been some hybrid practices in and around New York City that are now having capabilities for giving bispecific antibodies. Predominantly, it used to be at academic centers. Teclistamab, talquetamab, all these were focused, but then now it's come, we have some of our practice partners who now have with an affiliation to the hospital that are now starting to offer teclistamab. Sometimes they would prefer us to oversee for the first cycle or two, but I think in the future, once the risk for CRS has abated, like Dr. Phillips is alluding to, I think it just can be given in the community as well.
Okay, the next question. It's a good question. How do, these are all great questions. How do oncologists determine what treatment I should start with? And does the order affect the outcome? Go for it, one of you. I'm assuming this is maybe in myeloma, but this is pertinent to lymphoma also, yes.
I'll just take a 1 minute stab at this, and because, I think especially for myeloma, there are many factors we consider for determining treatments and in between immunotherapies as well. First of all, patient factors, disease factors, and environment factors. Patient factors, you try to always see what is the performance status, and that's so important. We all keep harping on about performance status, but that has a huge amount of importance into the type of treatment we will plan for you. Your history of infections, how you've responded to treatments in the past, all that are taken into consideration. And for disease characteristic, what all drugs has the disease kind of been exposed to. Inherently, is the disease exhibiting signs of high risk versus standard risk? and some of the environment factors as well, logistical support, family support, because for some stem cell transplant or CAR Ts, these are also important considerations. And now regarding conventional chemotherapy, we have a lot of data that shows like after certain classes, these particular classes work. But if your question is particularly with, do CAR Ts need to go first or do bispecifics need to go first? We now have data coming in, although that's not changed anyone's practice yet. But, the 4 out of the 5 approved CAR Ts are right now, immunotherapies are right now directed against BCMA, the B cell maturation antigen. So there's a lot of talk happening at all our conferences in what is the right sequence to do this. There's a whole lobby of patients, of doctors who are like, those who are CAR T eligible should get CAR T first, and then if progress should go to bispecifics and vice versa. But there's recently a paper that came out maybe a month or 2 ago that that looked at what is the percentage or what is the amount of this BCMA that's present in the cancer that comes back after it's been exposed to either CAR T or bispecifics. And the punchline is that the researchers, at least for the number of patients they looked at, they saw that the amount of BCMA protein that was expressed was a little bit lower in those who had bispecific antibodies, and that's been thought of or postulated because of the continuous mode of administration. So at this time, there is this theoretical evidence that the same target CAR T following a bispecific may not be as effective. However, that hasn't really changed our practice yet, and we are still on the lookout for this data. But again, primarily we decide by looking at all these factors.
Okay. Yeah, we don't know how to optimally sequence in myeloma. And sometimes some other factors, like it's how fast is the disease progressing? I mean, this patient has rapidly progressive disease. I might not have the 2 to 3 months to wait for the CAR T to be manufactured and have to do something more urgent. So that goes into also. So question from the audience, are BMT increasing in military service members who served in Iraq? My husband had essential thrombocythemia, myelofibrosis, then a bone marrow transplant in 1022, and was exposed, it sounds like, to benzenes and diesel fuels. There is, I don't know firsthand specifically with military service members in Iraq. There are definitely good data from exposures with other things of an increased risk of cancers, and this wouldn't surprise me. Do any of my colleagues know more about this than me?
I don't. I just would assume with the military, they're always exposed to something, unfortunately. Yeah. From the time I was in the VA, so the blood cancers typically I think the incidents are higher than what we typically see in the general public because of what they've been exposed to, unfortunately.
Yeah. Is there a role? So I would like to know whoever asked this most recent question, is there a role for autologous transplant versus allogeneic? Do we know what disease, whoever asked this question, are we talking about myeloma, lymphoma, multiple myeloma? Okay. I'll let anyone who wants to talk about this. Is there a role? What's the difference between auto and allo in myeloma?
I can actually take a stab at it, and then we can also hear what Dr. Rajiv has to say. But so, in terms of transplant for multiple myeloma, autologous transplants are like the poster child of multiple myeloma. So they have been, shown to have really great outcomes in this patient population. And really, I've only seen one patient with multiple myeloma, and that patient had plasma cell leukemia, for which allogeneic transplant was recommended. Otherwise, for patients with multiple myeloma, sometimes they can develop secondary malignancies and secondary leukemias, in which case also they might be taken in for an allogeneic transplant, but there should be no role of allogeneic transplant for multiple myeloma going forward. And I was recently listening to another talk from some experts talking about the new treatment guidelines for plasma cell leukemia, which being a very rare disease, is unfortunately not very easy to study, and the treatment, is very different, especially after the newer agents came in for myeloma. So they are now recommending, even for plasma cell leukemia, to not go ahead with allogeneic transplants.
I completely agree. I think, there has been a lot of historical data looking at allogeneic transplants in terms of efficacy, but there were recently a lot of studies that showed that the unacceptable limits of toxicity, and the toxicity cannot be, in any way explain away these benefits which are being afforded by treatments not so intense as allogeneic transplants. So in modern multiple myeloma treatment, except if they have like an MDS or an evolving chip or other secondary cancers that may evolve from completely changing the stem cell population, we typically never do.
Yeah, as someone who I treat all the blood cancers and do allo transplant. We largely don't do allogeneic transplant anymore in myeloma based off our newer and safer therapies. I will say there are very rare scenarios where I'll still entertain it, particularly in a very young patient with very, very aggressive disease. Like a 30 to 40-year-old with what we would call high risk features with ugly genetic mutations, and even then it's still, I try to funnel towards good clinical studies with some of our newer stuff, but that would be the one scenario where I would still consider allogeneic transplant in this disease. All right, what is the most important thing to discuss with my doctor regarding bispecific treatment in lymphoma? What should my first question be? So Dr. Phillips, if you had to advise this patient, what would be the one question they should ask their doctor or you if they were being recommended a bispecific?
Well, I think it depends on the disease, whether it's even an option, but I think the physician's experience and comfortability with managing the side effects. Again, we talk about CRS, we talk about ICANS, but again, ICANS not necessarily much a big issue, and CRS, when properly managed and managed in an appropriate time frame, does not really escalate into a big problem, and something that can be really managed conservatively. So your physician's experience with these treatments is probably most important as of right now, because again, I think all of us who've had experience with these drugs have become quite adept at managing the adverse events and preventing escalation of CRS to where our patients are going to need intensive care. And we can manage most of these on the general floor, even as an outpatient. So if your disease is appropriate, large cell lymphoma, follicular, I would say your physician's experience and whether they have, the facility should also have tocilizumab on hand just in case. But also that really also stems with the physician's experience, because if they are experienced with dealing with and managing the bispecifics, then it should be a very tolerable treatment. Again, you'll have maybe a few ups and downs for one treatment day during the step-up dosing. Thereafter, it should be very manageable. And if your physician isn't experienced, then whether there's somebody they can refer the patient to initially to get started and then thereafter. If follicular, again, it can be given before or after CAR T. If this is a large cell lymphoma patient, your first question should be, am I eligible for CAR T? And if you're not, then again, the discussion for bispecifics.
Yeah, and again, yeah, it's more like it's experience and like the infrastructure in place. Like I'm at a university, we just started giving these bispecifics outpatient, and we have a plan in place where they'll get a nurse call, what to do if they have a fever. We have all these protocols in place to manage these things, and it can be quite complex. So, I would ask, what do I do if I get a fever at home? What's the next step? Do I come, and make sure that they've thought through these things? And, it took us some time to figure this all out. We had committees, so it can be challenging, but these can be done really safely once the appropriate measures are in place. All right. The next question, it looks like we got some, how can I reduce my risk of CRS on Columvi?
Yeah, so yeah, unfortunately, a lot of those issues are outside of patient control. I wish we don't know who's going to really have high risk of CRS. Unfortunately, a lot of the things that we constitute, high disease burden, et cetera, doesn't really probably play such a risk. It's really patient specific. So you really can't really do much to reduce your risk. To the point that you previously, I would say making sure you're aware of the things to look out for. And if you happen to go into an emergency room, especially one that's not affiliated with your hospital, make sure that they are aware that you have received the bispecific antibody and that they don't just work you up for infection. Because unfortunately, cancer patients' fever is a knee-jerk reaction for ER doctors to think infection, and they ignore anything else. So unfortunately, patients need to be advocates for themselves and say, hey, I'm on a different type of treatment. They've said that fever can be a side effect. this is a drug I'm taking. Maybe you want to look into it or call who I'm treating, because again, it's not just infection that you need to be worried about.
Yeah. And Columvi, which is glofitamab, right? That's glofitamab.
That's GloFit, yeah. That's glofitamab.
Yeah, there is, they didn't randomize this, but in the initial study, the phase 2, they changed, some patients were mandated dexamethasone versus a steroid. So dexamethasone is a steroid, and there's all sorts of other steroids you could use. And in the study, they said, use some steroid, whatever you want, but then they changed it where they told the doctors to give dexamethasone. And there appeared to be, now this wasn't randomized or controlled, there appeared to be less serious cytokine release syndrome with the mandation of dexamethasone. So our practice at UCSD is we've built in dexamethasone into the treatment plan. Yeah.
So that's in the label now. So the label.
Oh, it's in the label now. Okay. So
the label for Epcor and GloFit mandates steroids on the day of infusion for GloFit and for the first 4 days for Epco. So if they're treating per label, they will get steroids.
yeah. So good. I didn't know that was in the label now. So and then so we have a question for I live in a rural community. Do we have equal access to treatment options here, or will I need to be close to a city? Is the prognosis better for those who live in a large city? So that's a hard question. And I don't think we can really say that the prognosis is worse. You know, whether there's access to CAR Ts and these other things, that could be an issue. So what I usually what I would recommend is you can get great care in the rural community. There's great physicians out there, but it wouldn't be unreasonable, especially when you're doing well, to make sure you have someone that you're set up with at a big city, whether it's virtual or whatever, that you can establish care with. So if things change in the future, you have access to a physician who may have access to different therapies. Does anyone else have something to say about that?
I think with large cell lymphoma, though, unfortunately, if you don't have access to CAR T and your cancer does not respond to initial therapy, it is worse because, again, unfortunately, we know from Scholar One, patients die because they get more chemo. So I think it really depends on the cancer you have, whether and how you respond to sort of initial therapy, how that impacts it. Because if you're a large cell lymphoma person in a rural community, you can't get access to CAR T. Your chances of survival are much less than those who can't get CAR T.
I think in the myeloma world, there's, I completely agree about lymphoma from whatever I follow with the lymphoma data. But in the myeloma world, I think getting to CAR T and getting to bispecifics, even if the 5th line or 6th line is important. And if your rural community does not have, I've been in so far 2 institutions within New York City, one for my training and one as working. And for both these institutions, which is Mount Sinai and Memorial Sloan Kettering, there are establishments and they have, we have patients coming in from all over, and patients tend to stay in a place called Hope Lodge or other places while they get treatment, where their caregivers can stay, or they are in their 30-day monitoring period of immunotherapy, etc. So I'm pretty sure many other major institutions also have patient and caregiver friendly housing options and consultation options. I think these are some things that you should take advantage of if you feel that this is not, if you feel that these therapies are not immediately available to you through your local oncologist. So I encourage you to look into that and utilize these opportunities.
Okay, well, that was our last question. We're out of time. I want to thank.
So I'll just say one other thing that you said before. I think second opinions are very important.
Yeah.
Whether virtual or in person.
Yeah. Second opinions are important, but as someone who gives second opinions and I've had second opinions, when we get the second opinion and when I do it, I am getting a snapshot of the patient, and as opposed to the primary oncologist who has years of experience with you. So it can be challenging. I find giving second opinions very challenging because for that very reason. And ideally, when these second opinions are given, there is a phone call, which almost always is the case, in communication with the primary oncologist, because they're the ones seeing you every day and really knows you, and sometimes knows really what's best. So, but with that, it is time to close this out. I want to thank my colleagues who took time off on their Saturday for what I think is a very important cause, getting to talk to patients. And I want to thank all the patients who were in attendance. And of course, I want to thank Grace, our hosts, for putting together this wonderful talk. So thanks again, and hope we can do it in the future.